Good morning, everybody, and welcome to the 41st NKF Annual Patients Event. Only the second time we have held it virtually. And next year we will be back face-to-face on the 23rd of September at the Radisson Blu Hotel at East Midlands Airport. Hope to see you all there. We also had to hold our KPA Day virtually last April, and we had excellent speakers and updates regarding the work of the NKF. Updates were given on peer support, KPA support group, and increasing home dialysis campaign and the renal service transformation program. The increasing home dialysis campaign is making great strides, and we've been working with others to standardise the reimbursement of the utility costs for patients. We also have an in-depth benefit support page on our website. As we know, the cost of living is soaring. NKF has now 24 home dialysis peer supporters, all are volunteers, and have supported over 54 patients during the last year. This is a national service. The Kidney Patient Association support group has been set up for the NKF to help support local KPAs. There's also a WhatsApp group available for all KPAs to join and gain support from each other. The NKF continue to work closely with NHSBT and NBTA, and a joint webinar was held around opt-out. This was the second year of running this webinar. The NKF has a representative on each of the Renal Service Transformation Programme work streams and on the board, and you will hear an update during this event. The All-Party Parliamentary Kidney Group has a new acting chair, Laura Farris, and she will be formally voted into this position of chair next Wednesday on the 19th, and we will hold a further APPKG meeting in January. Today we have a great lineup of speakers. They are all an engaging mixture of patients and professionals, and we hope you find them informative and enjoyable. The NKF is extremely saddened by the death of many friends over the past year, and one of whom being our own NKF Secretary, George Palmer. So let us not forget our friends who have died since our last meeting. And I would ask you to have a 1 minute silence in remembrance of them. Thank you. Thank you very much. Can I just remind everyone the council meeting will take place at 2 p.m. and the Zoom link for that meeting has been sent to everyone who has registered. I will now hand you over to Pete.
Well, thank you very much, Jim, and welcome to the NKF virtual patient event till 1:40 this afternoon. As Jim said, we've got a packed programme today. If you'd like to ask any of the presenters any questions, all you have to do is type them into the chat box on the right hand of your screen. Now, we're going to be looking today at the dialysis decision making, hear from the couple of patients with their transplant stories, a fascinating look at the Renal Services Transformation Programme, hear from two lovely ladies who are on dialysis, talk about COVID, how could we forget about that, and we're going to kick off with Professor Simon Davis and David Coyle regarding the Bistro study.
Good morning, everybody. My name is Simon Davis. I'm a clinical researcher and nephrologist based at Coyle University and the University Hospital of North Staffordshire, and I'm chief investigator of the BISTRO trial. David, do you want to introduce yourself, although I'm sure people know you?
Hi everybody, I'm David Coyle, and many of you will know me as a member of the NKF executive, but today I'm wearing my other hat as a patient co-investigator in research.
Thanks, David. So I think if we, Pete, can we move to the slides and I'll explain how this will work. Thank you very much. So first of all, I'd like to sort of really express my deep gratitude to the NKF for giving me the opportunity to tell you about the BISTRO trial. I'm a great believer that research should be properly disseminated to patients, but especially when patients have been such a large part of a study and how it works, and hopefully it'll have some useful outcomes for them. So the BISTRO trial, what I'm going to do is present the main data, and then obviously we'll take questions at the end, but also David will, I think, say some words after I've finished about the involvement of patients in both the design, the delivery and the dissemination of this trial as part of our Q&A at the end of the session. So the first question I wanted to address is, why do we do the BISTRO trial? What's it about? So as many of you will know, that when you start dialysis, it's usual that you've still got a little bit of kidney function left. And we know from observational studies that if that is the case, then the longer that kidney function that you have of your own lasts, then generally that has benefits for patients on dialysis. They generally feel better, they have a better quality of life, and indeed they probably will actually have better survival on dialysis. So we know this is a really, really important part of what we should be trying to preserve in hemodialysis patients. But surprisingly, there's actually been very few trials or studies that really address this problem. We also know that when you're on hemodialysis, when they're removing fluid on the dialysis, which we all know has to happen to compensate for loss of kidney function, but if that fluid removal is quite aggressive and it causes dehydration during the course of a hemodialysis session, that can switch off that remaining kidney function. So what we wanted to do in the BISTRO trial was to see whether, if we used a standard pro forma that encourages people to approach the setting of the target weight, which is how we manage this problem on dialysis, if we could have a process of setting that which was standardized, could this preserve residual kidney function longer? And in particular, we wanted to know whether using a bioimpedance device, which is an electronic measurement that is taken from the patient's body to try and measure the amount of fluid in the body, could that help improve the preservation of residual kidney function over time? So this is that structured pro forma that I was talking about. You won't be able to read all the detail on this slide, but it just shows you on a single side of A4 that we encourage clinicians, or we ask clinicians, to use this as a pro forma to help them think about setting the target weight correctly. It has on it some important information on the left-hand up corner, like the current weight, the blood pressure, and on the right-hand side, a series of questions or comments are asked for the clinician to think about that might affect how you might set that weight. It thinks about physical examination, about the likelihood that the patient is putting on or gaining or losing weight, whether or not the patient has extra fluid gains on dialysis, between dialysis sessions. Obviously thinks about blood pressure, and importantly, and you won't be able to see this, but it also takes the patient's preferences into account. So it actually asks whether the patient felt better with a lower or a higher weight on dialysis. And I'll come back to that towards the end of my talk, because I think it's really important. So this was the pro forma that they used. And of course, they were asked to make these measurements on a standard way. So initially every month after starting dialysis, and then once things were settled down, every 3 months for the next 2 years of follow-up in the study. So just to say a little bit about the conduct of the studies, you can see here from this slide that this was a UK-wide study. It involved 34 centres across the United Kingdom, all of the provinces, and we recruited a total of 439 patients to the trial. You can see on the right hand of this slide that we started recruiting in about April 2017. We finished that recruitment process in October 2019, and the trial finished completely once everyone had 2 years of follow-up at the end of September 2021, in other words, last year. So this is the main outcome of the trial I'm going to show you on this slide, and it's important for me to explain to you that it's when you're doing a trial of this sort, really big trial with a lot of money being spent, what you have to do before you do the trial is make predictions. You have to say, well, we think this will happen, and then you're testing against that what actually happens when you do the trial. And we looked at a lot of papers that are written about residual kidney function in hemodialysis patients, and we estimated from those studies that we expected by about 1 year that about 25 to 30% of people will have lost their kidney function. And from that, we predicted that in a trial of this size, we would see about 185 people lose their kidney function over the 2 years of follow-up in the study. What we actually found when we did the trial, however, was that only 72 people lost their kidney function during that 2-year follow-up. In other words, that was much less likely to happen than we were expecting. And you can see here in the lower part of this graph, these two lines, the turquoise and the red line, you can see the two limbs of the trial, which were the patients who had the bioimpedance shown in the red, and the patients who did not have the bioimpedance shown in the pink, in the turquoise. Remember, all the patients were using the pro forma. And you can see that bioimpedance was a bit better. If you added bioimpedance in, it looks better on that graph. It's a slightly lower rate, but actually by 2 years, there was no difference between the two groups. So the bioimpedance itself did not seem to add to this pro forma in terms of improving the rate of loss of kidney function, but that was much less rapid than we were expecting. Now, we also measured a lot of other things in this trial, what we call patient-reported outcomes. In other words, things that are really relevant to patients in terms of how they live and feel, which were very important to measure. And this, I've just chosen one of these because there's a whole bunch to show, but I've only chosen one, which is the dialysis recovery time, because this actually turns out to be really important. It really predicts how well people do on dialysis treatment. And you can see on this, so if you look at this sort of coloured bars here, you can see the two extremes at the end. So the pink at the top of these bars are people who get better from a dialysis session within minutes. And at the bottom of that column, you can see in the purple colour, people who literally don't feel better after a dialysis session until just before they start the next dialysis session. In other words, 2 days later. And you can see there's a wide range of that. With varying recovery times reported. And over the course of the 2 years, you can see that there's a very slight drift, slightly fewer people in the top pink bars, perhaps a few more people in the blue bars, which were feeling better by the next morning. But there's no difference between the two groups. So if you had whether you've used the bioimpedance or just the pro forma on its own, there was no difference between those. And I can tell you from comparing this to other studies that actually this is still quite good. This lack of change over time is relatively slow in this patient cohort. So one of the questions we wanted to ask was, why did the bioimpedance not improve things? Why didn't it make it better? And the answer to that is, it turned out when we did an analysis after the event that actually the doctors and nurses setting the target weight were doing just as good a job as whether they had the bioimpedance or not. In fact, they were doing a very good job. On average, there was no difference between the target weight set by the doctors and that measured by the bioimpedance device. In fact, the doctors and nurses were doing exactly what we asked them to do, which is to stop patients from getting dehydrated at the end of a dialysis session. Of course, with some variation in that, but on average, there was no evidence of average dehydration at the end of a dialysis session. We also observed that when they increased or decreased the weight, that actually that was done in the two limbs of the study in just the same way, whether or not they had the bioimpedance or not. Now, you'll also remember that I mentioned earlier that we asked them to document what the patient's preference was. And I'm pleased to report that in the vast majority of cases, actually the fluid assessments made by the doctors and the nurses seem to be very much in agreement with the comments made by the patients, or the preferences made by the patients. To try and illustrate this to you, I've got a slightly complicated table here, but I just want you to focus on a couple of figures. So, for example, in this study, I think there was something like 3,000 or more than 3,000 fluid assessments made. And when the doctors or nurses wanted to increase the target weight, only 1.4% of the patients disagreed with that. They wanted to be at a lower target weight. And likewise, if they wanted to decrease the target weight, just 2% of those fluid assessments were associated with patients thinking the opposite. The vast majority of cases where it was measured, patients did seem to be happy with the changes that were being suggested by their clinicians. So I think that's really important. So I'm now going to just summarize my thoughts about the trial before we open it up to discussion. First of all, our main conclusion from this study is definitely that the rate of decline of your own kidney function following the start of dialysis treatment is much slower and lasts longer than we had ever realized. And I think this is a really important finding. This may be because we are using this standardized fluid assessment protocol, which allows people to focus on that kidney function. Of course, we were measuring it in this study. Many units don't measure this. I think this is now what I would call best demonstrated practice. What we found was that adding the bioimpedance didn't really make any difference to this, but as I've told you, that's simply because the clinical assessment was just as good as the bioimpedance. There was evidence that clinicians and patients agreed most of the time in their fluid assessments, which I think is encouraging. The other thing I would say is that in this trial, where we observed fairly good preservation of residual kidney function, actually dialysis-related symptoms were relatively low, fairly infrequent. For example, I'm talking things like cramps and dropping in blood pressure during the dialysis session. If you've got that residual kidney function, you need to take less fluid off, and that helps reduce the symptoms. And then finally, just to say a very important point, that we also, of course, are mandated to look for evidence of harm when you do a study. And I can report that there was no evidence of harm done in this study, and actually that the deaths and transplantation rates were exactly the same in both groups. So in completing my presentation, I just wanted to make some thank yous, because undertaking a trial of this size is no mean feat. And there are a number of bodies that really supported this. The management of the trial by the Coyle University Clinical Trials Unit. We had a trial steering committee, which was chaired by Richard Fluck. We had a patient advisory group that David Coyle chaired, and David may say a few words about that in a minute. We had an independent data monitoring group to make sure that we were reporting the data correctly. And of course, we had significant funding for this study from the National Institute for Health Research. But most important of all, I want to thank all the patients and all the site teams. I obviously can't do that individually to everybody, but I'm extremely grateful for the wonderful efforts and supports by patients and their clinicians from these 34 sites across the country that made this trial possible. Many thanks for listening to me.
Thank you very much, Simon. We've got just the one question for yourself or David, and that's about GFR. at what point GFR dialysis would be considered?
So it depends a bit on the patient's symptoms and things, but I think a GFR of around 7, 8 is when people are usually starting dialysis treatment. In fact, in this particular study, we measured it properly as opposed to estimating it from the so-called eGFR. And actually, I can tell you that at the beginning of the study, the eGFR in both limbs of this study was 5. Or 5.2 to be precise. And interestingly, it tailed off fairly slowly over the 2 years. So even by 2 years of treatment, the eGFR average eGFR in the study was around about 2.5. So that's new knowledge. Actually, people thought that it tailed off more quickly. I would like David to have the opportunity, if he can, because I think we've got a couple of minutes, Pete, just to say a little bit about the patient involvement in the study.
Yes, please do. We have got a couple of minutes. So, David, if you'd like to say a few words, go ahead.
Yes. So, hello again, everyone. So, the patient voice is very important in research, and the constant problem is trying to illustrate and demonstrate how the patient voice helps in research. So I'm just going to say 3 points about bistro. Firstly, the patient voice was represented right at the heart of this project. So myself, as a patient with lived experience, was on the core team. That meant I had access to every aspect of the study and could represent a patient point of view, which wasn't my point of view. It was my point of view and the PAG group's point of view. So I was backed up with a PAG group of patients from around the country, different ages, different backgrounds, which interestingly was a virtual group as well, which proved very useful when COVID hit. And the 3 examples of where working as a team, collaborating, patients can help. The first is when you're designing the study. So if you think about the profile of patients on this study, we're just starting dialysis. We can all remember that, those of us that have been through it. Our state of mind, we're worrying about things. It's a massive change, control in our life. So it's a very sensitive moment in our patient pathway. And what we were able to do is bring that to life for the people who were designing the study, so they could take that into account in what's called patient burden. So questionnaires are not too long, urine collections, blood samples, and it's important to take that into account because from the study point of view, this is a long trial and there's lots of data to collect. So unless you design it in a sensitive way, you won't keep the patients in the study. So in that design stage is very important. Recruiting patients to the study. So we were able to support the research nurses. So we all know when we go and see a doctor, we also quite like to talk to a patient as well. Patients talking to patients, very important. And whilst we didn't use that service very much, it was made available to the research nurses that if somebody was a bit unsure about the study, they could talk to one of the PAG group. So we made that available to them and raised the awareness about the study as well to help the recruitment. But the really important work was in the retention. As Simon said earlier, this was a very long study, delayed by COVID. So keeping participants in the study, very, very important. And so we did this in a number of ways. We had a whole series of personalised communications to participants. So we had little postcards welcoming them to the study. We had postcards at key points in the trial. We had a newsletter, which was a lot more than just this is a study update. It had 3 aspects to it because the newsletter was an absolute collaboration between the team. So we had an update on the study. We did articles about people in the study so people could understand what's involved. And we had a kind of a welfare element, which was particularly important during that COVID period of patients talking to patients with tips of how to keep going. And communication. So the look and the feel, the plain English, all of that. So there are 3 examples of the work we did. And why was this study important to me? But anything that helps us prolong our kidney function has got to be a good thing. And I found this very interesting, that here was a trial where the expected outcome wasn't as expected, and I'd never come across something like that before. But the learning that we've got around how to manage target weights and liquid management, that's the big success story for me in this. Hope that helps.
David, thank you very much. We've got one more question before you both go, and it says, were other medical conditions considered, like diabetes, high blood pressure, etc.?
Certainly they were, because it's a very important aspect of what happens in dialysis patients. So we measured that at the start of the study in terms of what different conditions people had. And we also encourage clinicians to think about that when they were setting the target weight. And there will be some secondary analysis of the trial showing how that actually influenced those decisions. But I can tell you today that the trial was well balanced. In other words, the number of people with different conditions in both parts of the trial were identical. We can also tell you that we found that when we're talking about the rate at which kidney function is lost, that actually age was the most important predictor of the speed at which you lose kidney function on dialysis. And interestingly, the older you are, the slower that is. So that counterbalances what we thought would be the case, which would be having lots of other conditions would mean you lost your kidney function more quickly. So it's quite an interesting observation, that, and we need to do some more work on understanding that data. But it seems to be that what you might think intuitively is that older people with more other conditions might lose their kidney function more quickly. It turns out that actually being a bit older is associated with better preservation of residual kidney function after dialysis.
I've got 2 more minutes, and I've just had another question come in. How is target weight decided?
So it's what I call a complex decision. And that's very important to understand. That is, it's not a single thing that tells you what that target weight should be. What you're trying to do is to assess what the right weight is, such that a patient is not got excessive fluid on board, but is not dehydrated. And some of those things can be done on regular questions, like, do you feel thirsty all the time? Have you got swelling? Those things can help you decide whether there's extra fluid or not enough fluid. But you've also got to remember that the weight is affected by how much a person eats, for example. So if they're eating well because they've started dialysis, they might put on weight, which is body weight, but not fluid weight. So that's why all those aspects of the measurements need to be taken into account. And the bioimpedance measurements didn't seem to really add to the clinical evaluation in that situation. But it is a complicated decision. And as I think we've also demonstrated very nicely in this trial, how a patient feels at different weights is also very important. I'm sure that most people on dialysis who've experienced having excess fluid or not enough fluid on board will have started to recognize what that feels like. And I think that this study shows that that should be taken into account by doctors and nurses when they're setting the target weight.
Well, thank you very much. Very interesting study, Simon and David, for your time. So next up is one of our NKF ambassadors. She is just 25 years old, always has a smile on her face. Welcome, Hattie.
Hi everyone, I'm here today to just give you a little bit of information about me and my experience with sort of the transplant process, dialysis, and all of that kind of good stuff. So that's what I'm going to be talking about with you guys today. So one of the main things I wanted to focus on in today's sort of presentation is just a bit about my journey through my 2 transplants at the age of 25, and just a little bit on how to stay positive and sort of how to fill your time and live your life even though you're going through this sort of process. So I'm Hattie, I'm 25 years old, and like I said, I've had 2 kidney transplants. I had my first one when I was just a baby. My kidneys didn't work when I was born, and I had my second one last year. I studied graphic communication at Bath Spa University. I graduated officially last year. Actually, no, this year. But properly last year, I've handed all my work in. So that was an amazing achievement and something I'm super proud of. And I just try and raise as much awareness as possible for chronic kidney disease online, and just try and inspire others and make everyone realize that it's not just something that can happen when you're older. It's also something that can happen at any age, whether you're born with it or whether it happens, you know, through teenagerhood or young adult life. It's something that can affect anyone. So, like I said, the main thing that I'm going to be talking about today is, what did chronic kidney disease look like for me? Because I know that this can look different for everyone, depending on what stage of your life you're in, what you're going through, your age, your circumstances. So, of course, everyone's journey is going to be completely different. But this is just a little bit about my personal journey. So my first transplant, as you can see, very tiny baby. I was born 6 weeks early at just 1.6 kilos. So I was very, very small. My dad actually had to go out and buy doll's clothes because even premature baby clothes didn't actually fit me. So that was fun. But yeah, so I had a lovely doll's outfit wardrobe. But yeah, I actually managed to avoid dialysis completely before my first transplant, which is incredible. I was very ill. I was sick every day, and on a concoction of medication, but luckily I managed to avoid dialysis, which was so lovely, even though I didn't really realize at the time what was going on because I was a baby. I had my first transplant on the 27th of July 1999, so I was only 2.5 years old. So again, very small, wasn't really sure what was going on, but just knew that there was lots of hospital visits, lots of needles, lots of obviously things that normal kids wouldn't necessarily have to go through. But again, it was kind of just part and parcel of life, and luckily I don't really remember that now. But yeah, so that's another bonus of having it so young, I suppose, is that I don't remember any of it. And when I did finally get my transplant, which was from the donor list, I think I was on the list for about 6 months in the end. It completely transformed my life, and my kidney actually lasted an incredible 22 years. And again, there were lots of checkups, and there were periods of time that I was unwell, as anyone could expect, really. But yeah, ultimately it did amazing, and it got me through school, and it got me through homeschooling because I was homeschooled for a long time, and university, or most of it, like A levels, meeting friends, going out and doing things. So it was incredible. And again, yeah, this is what my life looked like for a good 22 years. So going on holiday with my friends, going out at university, going sort of out to nightclubs, crazy to think because of COVID, obviously, happening the last few years. But yeah, enjoying my time, eating whatever I want. There was no worries about what I was consuming, going to concerts, dyeing my hair crazy colours, all the typical stuff, going to the gym, working out, and just generally enjoying my life for a good 22 years. It really was almost as if nothing was wrong, which is, I suppose, the whole point of a kidney transplant, is to get you to that stage where you are as healthy as you can possibly be. So that is absolutely what I was for a good 22 years. So in the lead up to my second transplant, I was at university. I was in my 3rd year of university, and I just started feeling not very well. I was very tired and started getting a few headaches, and just generally other sort of elements and levels in my blood were starting to just peak and trough and just look a little bit iffy. So in sort of 2019, my kidney started going a bit downhill, and my GFR started slowly decreasing, and it was just time to sort of think about dialysis. My hemoglobin actually was so low that unfortunately transplant wasn't suitable for me initially, so I had to go on dialysis just to try and get the hemoglobin up a little bit, because obviously there are risks related to low hemoglobin and operations. So that was kind of the first point of dialysis, was to try and just actually get all my levels to a point where it was going to be as safe as possible. So I have my neckline, my trusty neckline that served me for a very long time, fitted on May the 3rd, and I actually started dialysis the next day on May the 4th. It's not Star Wars Day, I think. So that was great, and honestly, it wasn't an amazing first experience. It was quite a stressful time, and adjusting was quite difficult with my studies and trying to let my university know and trying to complete my work still, and it was all quite a difficult time, but definitely starting was the start of that journey, and at least I knew at that point we were going to be getting somewhere towards getting my new kidney, I suppose. But yeah, the first sessions were difficult, but I got through, as everyone does. And yeah, so got there in the end. One of the big things was the support from my online community. So I have a Instagram account where I help others. I post a lot about the transplant process and journey and different medications I've tried and what's going on in my life, and generally sort of just give daily life updates as much as I can about what's going on, because if it helps one person, then that means the world to me, and I would have loved to have had that from someone else. So in relative to my age, because everyone I knew was so old going through it. So yeah, it was incredible to receive support from them, and even if they weren't going through it, it was really lovely to speak to other people and just have people outside of the situation supporting. I feel sometimes it can feel like a bit of a bubble, and that the only people supporting you are people you initially know, or your like doctors or your family or friends. And although that's incredible, sometimes it's nice to actually have a bit of broader support from an outside source. So that was really amazing. And everyone did not disappoint. Everyone was so supportive. Everyone asked lots of questions, gave their own sort of influence in terms of if they'd had friends or family that had gone through transplants. So many people have gone through kidney things, whether they know someone of it, or it's happened to a family member, or it's happened to themselves, whether it's a transplant, or it's incredible. There are actually so many people out there that you would never know that have gone through kidney transplant journeys. So it was amazing hearing other stories at that point from other people who had their transplant and were living their life to the full. So that was incredible. And yeah, like I said, just everyone giving sort of outside support was really, really nice, just because it meant that I wasn't on my own. And, you know, whenever I was having doubts about whether I could do this journey, there were so many people around me, and it just made the biggest difference. And it was just fantastic. So dialysis was a long experience for me. My dialysis in the end was about 2.5 years. And I had the neckline the whole time. I never had a fistula fitted because we always sort of were within reach of a transplant date. But unfortunately, 4 of those times it fell through. And I had a lot of exhaustion, as I'm sure many of you can understand if you're also on dialysis. Just that dialysis exhaustion is like anything else, unlike anything else. But yeah, so I was still trying to complete all my uni work and just get everything done, complete my course and actually graduate. And then COVID hit. So I was also trying to deal with that. And there was definitely a lot of different factors that influenced my dialysis experience that I'm sure wouldn't influence others. And that's why this experience does feel so personal, and obviously it's bound to be, but it's just so many things were happening at the same time that it all feels like a bit of a blur. But one of the main things that I experienced during my dialysis was my blood pressure slowly increasing. And I honestly don't really know why that happened. And I think many a doctor will also be scratching their heads about this. But my blood pressure slowly just was increasing over the time, and actually got to very high levels, as you can possibly see from the picture. And yeah, it got to around 230/145, I think was about the highest it went, which had everyone sort of a little bit scared, including myself. But it was a crazy time, and again, still got through. Just knew at the end of this journey there would be a kidney and there would be better days ahead. So that is kind of what I kept in my head the whole time, that this was temporary and it was going to be okay. There was lots of trial and error with medication. There were so many drugs that were tried and then didn't work, or my body reacted differently to. So I would definitely say, if you're struggling with medication, or you feel a medication dose is not quite right for you, or you feel like you would like to try a different variation of that medication, just a different, I don't know, drug in the same range. I'm not sure, it depends on your situation, but definitely, back yourself and just go for it, and try as many things as possible to make your journey as easy as possible for you, because there are always other options. And just advocate for yourself, and just trust yourself, just if you don't feel good, ask why. But yeah, I was really lucky that I managed to find different ones that worked for me in the end, and overall we got there. The main thing is just trying to stay positive. I think, like I just said, a lot of what I told myself was just, you can do this. The support from everyone was so incredible, and just reminding myself that it wasn't going to be forever. Everything is temporary, whether, it's you're feeling hungry, you eat something, you feel better. If you're feeling tired, you sleep, you feel better. Every feeling you have ever is temporary. So if you're feeling rubbish about dialysis and you're like super stuck in the situation and you don't think it's ever going to end, just know that it will. You will get to the other side and you will be okay, and you will be fine, trust me. I was there, I was in that moment, but you've got this. Eventually, I was ready for my transplant. I was so excited to wake up with a new kidney. It felt like such a long time coming after 2.5 years, and so many sort of cancelled dates and, disappointment and all the kinds of different variations of transplant process, I suppose. But I was so excited that it finally come to the day that it was going to happen. I was in the gown, I was ready. I had my kidney from my dad, actually, and I knew it was happening from the moment that I had the call up that he had gone into theatre to have his kidney sort of taken out, I suppose. And from that point I was like, okay, let's go. We're gonna do this time. And I was so excited. Obviously I was nervous about the coming months. I was obviously unsure about what was going to happen, where my levels had been so up and down, and my blood pressure was still quite high. There are always worries and anxieties, but I just knew that if I could get through that kind of initial few weeks, then we would be okay. So I think it would be almost inhuman to not be nervous about it. I think that's a completely normal kind of emotion to have, but ultimately I think you just have to stay strong and just realize that if you just get your head down, just get through it, and you can do it. It really was kind of a moment that I'd waited for my entire life. Seeing as I hadn't remembered my first transplant, it almost weirdly felt like this was my first transplant, because it was the first one I had sort of living memory of. And obviously when you've kind of known your whole life that this was going to happen, it's kind of a weird feeling. Obviously if you have deadlines at work or uni or anything like that, you kind of only know a few weeks or months before that something's going to happen. But when you've kind of known forever, it's quite a daunting thing to know that that thing is finally happening. So that was definitely something that I was dealing with. But it was almost like Christmas. It was really nerve-wracking but exciting, and just a sort of a new chapter of life that I felt like I hadn't experienced yet, because it was something that was completely new to me. But I really, really was just so happy for it to finally be happening, and just couldn't wait to wake up on the other side. And I think the results speak for themselves, honestly. So this is the 7-day post-transplant transformation. So as you can see before, I had a lot of fluid buildup. I really, really struggled taking fluid off at dialysis. It made me feel really unwell. I would get really dizzy. I would feel very dehydrated. I would feel really dizzy and everything after sessions and during sessions too. But unfortunately fluid buildup was a really big problem for me, as you can see from the first photo. But within 7 days, that was what I looked like. So that was kind of wild. Biggest accidental weight loss journey ever. So unfortunately my hair was a bit broken, so we could ignore the hairstyle, but ultimately you can see it made the world of difference, and I was so happy to just be rid of the fluid. I could breathe through my nose, which was a miracle. But yeah, it was absolutely incredible. So I remember sort of briefly waking up from the anaesthetic straight after the transplant, and an excited consultant standing at the end of my bed, just basically repeating, "It's produced 4 litres of urine in the first hour," which was quite strange to hear when you don't really know what's going on, but obviously equally very, very exciting to know that the kidney was actually working. So ultimately, that was the main thing that I took, because I know that occasionally it can take a little while for the kidney to sort of wake up, I suppose, but ultimately mine worked straight away. So it was such an incredible feeling. My blood pressure, unfortunately, didn't come down straight away. So I was in ICU for 5 days while they monitored my blood pressure and tried out a few new meds and slowly reduced some of the medication as different things started to kick in. But even within those first few days, the kidney was working amazingly and just doing pretty much everything it should, apart from controlling blood pressure. But it was okay. We would give it time to do that because it had a lot of work to do there. So it was just doing amazing. And I sat up after about 3 days because the blood pressure had been high and I was quite out of it, obviously on a lot of post-transplant medication. I didn't really sit up. I know a lot of people do, they get up and walk around, but just for me, it took about 3 days to sort of get up and out of bed. And I don't think I actually got out of bed at that point, but the physio helped me sit up, and it was nice to be vertical, even though it felt rather bizarre at that point. But yeah, my teddy bear got me through, so it was all good. The next few months were busy and also just again, at this point, it kind of feels like a blur, but I experienced lots of bloating, lots of euphoria, lots of kind of impatience, and just wanting everything to be perfect straight away. But of course, nothing's ever perfect straight away. Like, that's quite unrealistic. So I had a lot of experience of bloating, and the kidney that got put in me was quite large. So obviously I'm quite small, I'm about 4'10", so it was a big kidney in a small person, so that created lots and lots of bloating and just feeling very uncomfortable. So that was unfortunate, but again, nothing that could have been avoided. And yeah, it was just all slowly over time, things started getting better. The blood pressure came down and became completely normal, if not too low, which was a miracle and something I never thought would happen, to the point where we removed the neckline. So we got the green light to have my neckline removed on the 27th of August, which was exactly a month afterwards. And I forgot to mention that this transplant happened exactly 22 years to the same day after the first one, which was kind of freaky. But yeah, again, exact month later, the neckline got removed, and that was super bizarre, not having my line there after having it with me for 2.5 years. But it was lovely to have it gone and not have to shower with a piece of plastic there. And yeah, after about 5 weeks, sort of the bloating had calmed down a little bit. I managed to go out on quite a few daily walks and walk around the park. It was beautiful sunshine as it was end of summer. And yeah, I just started feeling like my energy had come back and I just felt like myself again, which was so lovely after so long of just feeling just rubbish on dialysis. But it was so nice to be feeling good again. And this is kind of just where I am now, really. I'm living life. I'm still being careful because of COVID. I feel like a lot of people are going out and doing everything, but I think with with everything that I've been through, I'm still very cautious about it. But I am slowly learning that going out is fine and you can go out and still be fine. But yeah, I go for meals. Me and my partner go for beautiful walks on the beach. We've been out in our camper van on holiday. We moved house and got a beautiful office, which I'm sat in now, and just don't have a puffy face and completely no energy anymore. I feel like a different person, honestly. It's like I've got my old self back. I feel like I did, during that 22 years, and that kind of 2.5 years of feeling tired and just rubbish are gone. The transplant has completely changed my life, and touch wood, it's doing amazingly still, and I couldn't be happier. And honestly, this is what post-transplant life looks like. The transplant is the end goal, and of course it's not a cure, it is kind of a treatment, but it really does make the world of difference, and life can continue with kidney disease. It's definitely not the end of the road. It is such a difficult thing to get through, and there's no denying that it affects your life, of course, but it doesn't define you. You have other elements to your personality, to your daily life. You know, it's not everything about you. You can have other things, and you are a bigger person than your kidney disease. A few of the things that helped me stay positive generally were journaling and writing down my feelings. I felt that really helped. I know, you know, I speak for myself, but I know that a lot of other people have said the same, that when they write their feelings down, it kind of slows their brain down a little bit and helps process what they're going through. And I definitely found this for myself. So just writing things down and sort of brain dumping onto paper really made the world a difference. So that's something I would definitely recommend. I took part in walking challenges and just generally got outside as much as I could. I signed up with the Conqueror events, I think they're called, and they're virtual walking challenges, and you get medals for doing them. And who doesn't love a medal? Like, everyone loves a medal. And yeah, it just really encourages you to get those miles in, get out and walk as much as possible, which I know really helped me for sure. My online community really helped, and just, you know, supporting other people, knowing that my process and what I went through can help other people is something that definitely kept me going, because, you know, if they need someone to look up to, I would love to be that person. And, you know, as much as other people helped me at the start, if, you know, you can create that chain of help, then that's just incredible. So I really am thankful for them, and so glad that I can help people through that. Obviously, watching my favourite films, Harry Potter, was on repeat as soon as I was out of hospital. Absolutely love Harry Potter. So yeah, just as much as you can, just fill your time with things that make you happy and things that you enjoy, especially through the recovery process and the dialysis process as a whole. If you could just fill your life with as much things that you enjoy and make you happy, you realise that there is so much more to life than your transplant process. And although, like I said, it's a big part, there are other things too, and you deserve to feel as good as you possibly can. I love creating, painting. I do as much of that as possible. So, you know, I just love art. I opened a little online store and designed my own earrings and jewelry and sweatshirts and all the kind of stuff, just to have some other form of creativity that I could create things and just enjoy my time and think of something else. So that really helped too. And something not mentioned on here, I also saw the unit renal psychologist, who really helped. She was incredible, and it was really good to speak to someone, again, kind of outside the situation, who could give quite a level point on everything, whether it was kidney related or not, or just general sort of anxieties on things. That really helped. So if your unit has one of those, or, you know, the NKF also have their helpline, if you feel like you would like to speak to someone sort of outside of your situation, then I definitely recommend it, because that really helped me. So those are a few things. And generally, I think it's good to reflect on reasons why, like, you're happy to be alive, because ultimately the whole of this process is to just keep you as healthy and happy as possible. So these are just a few, just to name a few, reasons why I am happy that I am alive, and why I'm happy that, although the process was difficult, it led me to still being here today. And of course, you can have a little read of all of those, but ultimately, the most important one is petting cute kitties. Definitely. So no, there's just a few things, but spending time with the people I love, you know, petting cute cats, obviously, but there's so many reasons, and there's too many to really name here, but so good to be alive. And that is just the main point, really. You got this. So yeah, thank you so much for listening. If you do have any questions, please let me know, and if you do want to contact me sort of on Instagram or anything else, you're more than welcome to. I'm happy to talk to sort of anyone about anything, really, if you have any questions for me privately. But yeah, absolutely, thank you for listening, and just remember that you will get through it. You have got this, and I completely understand how difficult it is, but there is light at the end of the tunnel. So thank you.
Hattie, thank you very much for that very moving story. And we've We haven't got lots of questions, but more of the comments are thank you very much. Inspiring and things like that. Talking about your Instagram, someone's put, I wonder if you made any friends for life what had the same situation as you when you posted about your situation.
So Instagram, I have actually made some friends for life. Genuinely, it's incredible how many people you can meet on such a sort of, well, small community, I suppose, in terms of the general people that are out there. I haven't made any friends for life within the kidney community, but I have made friends for life sort of outside of that, and that I have met up with in person and sort of keep in contact still to this day. And there are actually plenty of people within the kidney community too that have contacted me that I do speak to on a regular basis and check in with, and we still talk about, you know, their worries, my worries, and it's really nice to confer with different people about different medications and what worked for, you know, each of us. So there are definitely people that I recognize and I'm still in contact with as much as possible from there, yeah, which is lovely.
Thank you. Also, someone's put, when you were on dialysis, did you self-care at all?
I suppose, does that mean did I do dialysis at home?
No, did you do it yourself? So did you needle yourself or things like that?
No, so I was actually at a unit in Bath, so I didn't ever do it myself. I had hemodialysis, but I was at a unit the whole time. The nurses were honestly incredible. I had a proper little family there, and I actually quite enjoyed, well, I wouldn't say I enjoyed going to dialysis, but I enjoyed the community at dialysis. I had real friendships there, and I still keep in contact with a good few of the nurses now. And, you know, I consider them friends for life too, because it feels more like a family. I feel like when you're at dialysis, especially, well, that's how I felt personally. It was really just like a little family, because you see the same people every time, you see the same nurses, you see the same other patients. And although I didn't do it myself, so technically can't answer the person's question, but it really did help me going and being part of something and talking to other people about what they were going through at the unit. So that worked really, really well for me.
Now, you touched briefly that you've got a partner. Now, I know the story behind this, and you actually met him while lockdown was going ahead, didn't you?
Yeah, so we actually met on the dating app. And I was in lockdown and he was in lockdown, and we just instantly clicked, and we started messaging and FaceTiming, and we actually had our first date on my balcony, sat 3 meters apart. So that we were still social distancing. But yeah, it kind of went from there, and he moved in a few months later, and we've been living together ever since. And he has been such an incredible rock through this whole experience. And I would have had to have done it without him, but I don't know how I would have done it without him. He is so amazing and so supportive, and just such a coincidence that we met at such an unlikely time. But yeah, I just love him to bits, and it was amazing what lockdown brought to me in a way.
And just done some amazing fundraising for the National Kidney Federation as well, hasn't he?
Yeah, so he's actually just walked the length of the Cotswold Way, which is incredible. So he did a 102-mile walk in 8 days, I believe it was in the end, and raised £900 for the NKF, which is just outstanding. So I'm so proud of him, and we just can't thank the NKF enough, really, for everything they've done for us. And it was just, as much as we could say thank you, that was what he did. And he's an incredible guy, and I'm sure he'll do many more challenges in the future, and that was the first of many. But it was a big journey, but one he's proud of doing, and one I'm very proud of him doing too.
Well, we would like to thank you for today, because that was absolutely fantastic. So thank you very much, Hattie.
Oh, thank you.
Oh, it's our pleasure. So next we have 4 very interesting speakers explaining the Renal Services Transformation Programme. And kicking it off is Lydia.
Hi, thank you. And thank you to this morning's speakers, some really interesting talks. And Hattie, I totally love Harry Potter and medals as well. So completely agree with you. So hi, everyone. My name's Lydia Ball. I am the lead commissioner for the Renal Services Clinical Reference Group. I'm going to try and explain a little bit about what that means, and also about some changes to commissioning that are currently taking place across England. I'm then going to pass over to some of my clinical colleagues who are listed on the screen there, so we can explain the various different work streams that are taking place across the renal transformation programme in England at the moment. And I'm just figuring out how to work the clicker thing to make the slides move on, so please do bear with me. So in terms of the clinical reference group, just trying to get to the next slide, apologies. So, apologies. I seem to have a bit of a delay with my slides. Would somebody be able to move the slide on for me? Would that be okay? Thank you very much. So what is a clinical reference group? I'm really conscious that in the world of commissioning, we talk about a clinical reference group, and actually, what does that mean? You know, I certainly didn't know what it means before I came into a sort of commissioning world. So essentially, it's a nationally based group that provides clinical advice and leadership on specialised healthcare services in England. And it's made up of expert clinicians, commissioners like myself, public health experts, and patients and public voice representatives. And what do we do? You know, what's the purpose of us? So we advise NHS England of the best way to provide specialised services. And what does that really mean? So it means that we essentially lead on the development of clinical commissioning policies, service specifications, and quality standards. And actually, what that essentially means is we produce the policies and the service specifications which define the standards of care that NHS trusts in England have to follow in order to be able to provide specialised services like renal replacement therapy and kidney transplantation. And I think the key thing to say from an NHS England, both a clinical reference group perspective, but also within the development of all of commissioning policy and service specification, the patient and public voice members are at the absolute heart of everything that we do. So within the clinical reference group itself, we have patient and public voice representatives sitting on that group, but within the development of the policies that we produce and the service specifications that we produce, there is always patient and public voice engagement. Next slide, please. So just trying to explain a little bit about what's going on with commissioning at the moment in England. It can be a little bit confusing, so I'm just going to try. My slides are a little bit busy, so I'm just going to try and pick out what I think are the really key points that hopefully make this a little bit clearer. So back in July this year, the new integrated care boards became statutory bodies. So there's 42 integrated care boards across England, and what we are doing as NHS England is we are delegating some of the specialised services that we currently commission to those integrated care boards to commission themselves regionally. So what does that mean? It means that there's no change to what's currently commissioned. So everything that we currently commission as NHS England in terms of specialised services, so for renal replacement therapy, for renal transplantation, there's no change to those services. And those services will still continue to be legally maintained by NHS England. We're just delegating the delivery of them and the responsibility of the delivery of them to the integrated care bodies. Now, the idea is that the some of the services will be delegated from April 2023, so that's obviously April next year. Some of the services will be delegated a little later, and some of the services are actually, it's for such specialised patients, they won't be delegated at all and they'll be retained by NHS England. And I'll come on to that in a moment. Next slide, please. So why are we doing all of this? What does it actually mean? What's the point? So we're doing this because we feel it will improve quality of patient care, equity of access for patients across this country, and it will improve value for money for the NHS and the taxpayer. So from a quality of care perspective, how is this going to improve that? You know, what difference is this going to make? And actually the purpose of pulling together commissioning at an integrated care board level, so at a regional level. That means we can join everything up. So the integrated care bodies for a particular region can join up patients' care, and they can look at a patient's care from a primary care level, so at a GP level, through to secondary care in the hospital, through to specialised care. And enabling them to do that will provide a more holistic, better access to care model for patients. It will provide a multidisciplinary approach, and it will increase focus and investment on preventative care. So as I say, being able to look at the commissioning of services and the money flows right across from GP level right through to specialised services. So it'll improve equity of access, because the IC, the integrated care bodies, will be able to look at what are the needs of our population within this particular area. Do we have a high prevalence of kidney disease, for example? Do we need to put additional money into kidney disease, use this as an example, within our area? And do we need to think about how we really invest, because we do have a high population of patients with the condition? In terms of equity of access, it will also provide integrated care services with the opportunity to try and level up access to services across the country. And as I say, NHS England will remain legally responsible for the delivery of services. So we will have processes in place where we're able to look at what service delivery looks like across the country. And if there were any issues, we'd be able to step in and try and support our trusts and integrated care body colleagues to resolve those. And finally, we think it'll improve value for money across the NHS. So we think it could, by investing in preventative care at the GP level, we think that could reduce demand for specialised services, and specialised services are very expensive, as I'm sure you can imagine. So by actually identifying patients in a community setting, we can subsequently avoid the need for them to access specialised services like dialysis. If we can identify patients at an earlier stage in their kidney disease, hopefully they won't ever need dialysis, in which case we can reduce the overall cost to the NHS, but more importantly, the patient experience. And we also think that by sort of pooling and delegating budgets at a regional level, that enables any underspend, so any money that's not been spent by the end of the year, to be shared or reinvested within that particular region's within that particular region. So the region can then decide what's best to do with that pot of money next year for their population of patients. Next slide, please. So I mentioned that services are being delegated in these sort of three pots, not the right word, approach, but we'll go with pots. So as I mentioned, there's a number of services. So there's 65 services, and this is across all specialised services. So that's all clinical specialties that we're looking to delegate as of April 2023. Now, from a renal perspective, renal replacement therapy is within that category. So that means these services, including renal replacement therapy, have been identified as a service that are suitable to be delegated to an integrated care board level, and are suitable to be led by the integrated care board within each of the regions. Now, just because we've said that we've proposed that they could be delegated, we are working with integrated care boards to ensure that they would be ready to take on these services. And if they're not ready, then we will be working with them to do an iterative approach to delegation. So it's not a blanket, everything will be delegated if a region is not ready. There's 27 specialised services that we've said, well, actually, we do think they would be more appropriately and better managed for patients by the integrated care board, but they're just not quite ready to be delegated yet. And there's so many reasons why that might be. But within this category, renal transplant does currently sit. So from a renal transplant perspective, we're saying, yes, absolutely, in the future, we feel it should be ready for greater ICS leadership. But actually, at the moment, we're going to retain the commissioning of that by NHS England, and we'll look to delegate that in the future. And that's primarily because there's a review at the moment called the Organ Utilisation Review, and we're awaiting the outputs of that report to make sure that we delegate that service in line with what's being recommended. And then finally, there's 81 specialised services that will not be delegated to integrated care service level. And they are, in the main, highly specialised services. And what that means is they're services that support a very small cohort of patients in this country who generally have very rare disease. Next slide, please. So that was my commissioning update, and I've tried to keep that quite succinct. I know there was a lot of detail on those slides, apologies for that, but hopefully that just gives you a flavour into what it is a clinical reference group does, what's the point of us here, and the importance of that group, and also why we're doing the changes to commissioning that we're doing. And I think it's really key to say, you know, the changes to commissioning this are happening at the moment are all there to improve access to services for patients and to improve the care for patients. So just to really highlight that today. So now I'd really like to just introduce the Renal Services Transformation Programme and my colleagues. So what is the Renal Services Transformation Programme? And I'm going to shorten it to RSTP because it's very long. So the RSTP is essentially a transformation programme that's being run by NHS England that's looking to transform the delivery of renal services across England. And why are we doing that? We're doing that to support better healthcare outcomes for patients and for service users. What's the impact of this? Why are we doing it? So it's about improving equity of access for renal patients. It's about a better experience for renal patients through the care pathway, reducing waiting times, a smooth transition between paediatric and adult care, and it's about improving care closer to home where that's considered safe. And as I mentioned, commissioning and putting that whole person and whole patient care pathway into one commissioning process is key to all of this as well. Next slide, please. So the RSTP has got 5 work streams: system working, acute kidney injury, transplant, dialysis and chronic kidney disease. And my colleagues are going to give you an insight into some of those today. We're looking at how do we take those work streams and the outputs that they produce, how do we implement those? So we've implemented and we've introduced renal clinical networks across England to implement this transformation to patients, to trusts and across the country. We've got regional teams that are supporting the implementation of this. The integrated care systems will be critical to the implementation of the RSTP outputs. And then we've got the NHS Trust, to whom in NHS England we refer to them as providers of services, but they're basically NHS trusts. And we've listed some outcomes there on this slide for you, but essentially we're producing data dashboards, we're producing toolkits to support hospital teams for best practice. You know, how do they deliver best practice for their patients? And we'll be doing a service specification review. So I touched on service specification earlier. It's one of the roles of a clinical reference group. We're looking at all of the renal service specifications that currently exist. So if you remember, that's the standards of care that we expect NHS Trust to deliver for renal patients. We're looking at how do we improve the current service specifications? Are they fit for purpose? How do we review them and reference our toolkits, our best practice toolkits? So next slide, please. On that note, I will introduce my colleague, Dr. Smita Sinha. Smita.
Hello everyone, so my name's Smita Sinha. I'm a nephrologist at Salford Royal and I'm trying to improve the early pathway for patients living with chronic kidney disease. So I'm going to have a go at this slider. There we go. So this is very small, and I'll try and run through it briefly, but this is a made-up case which was produced by NHS Right Care. So it's an organisation with the NHS which tries to show the impact of various different diseases on people individually, on their life, but also on the NHS budget. I'll run through it, but it's a gentleman called Abdul who is 30 years old, had a health check, and it's made up, had a health check done at work, which showed he had some blood and protein in the urine, but it was put down to a urinary tract infection. He felt fine, didn't have any symptoms, so didn't worry about it and didn't make any other appointments with his GP. At the age of 40, he went in for his NHS health check, and he was noted to have slightly high blood pressure, but again, he didn't have any other risk factors. It wasn't too high, so he didn't come back for a repeat test, and he wasn't recalled for a repeat test, and again lost. Several years later, he reattended, and this time with a chest infection, and was diagnosed with acute kidney injury. So that's when the kidney function has declined suddenly because of something else happening. And again, he got better, but his general health started to decline, and then a few years later he was admitted to A&E and diagnosed with CKD, but at the point where he needed to start dialysis. The rest of the slide talks about the complications that he experienced, and you'll have heard of people having complications from a heart and cardiovascular point of view, the challenges with access to transplantation and a waiting list, and that sometimes if you wait too long, that can still cause problems down the line. So what this case did was showed a really strong narrative about the importance of managing CKD earlier and identifying it earlier, so we've got more chances to make an improvement. And it's really important for us, not just at an individual level, but at a population level. So this is data from an audit that was done 5 years ago now called a CKD audit. And what it showed is that there is quite a lot of prevalence around the variation in prevalence around the country, anywhere from 3% up to 9%. But you can see on the map of England there, different areas have different prevalence. Our population is aging, so just like our joints age, our organs age, so we see more kidney disease as you get older, so we're going to see more of it. Our population is perhaps not as healthy as it used to be, so we're more likely to see people with diabetes, and diabetes is a really common cause of kidney disease. We're really lucky in renal medicine, though. We've got two really simple tests that can help us diagnose patients, and I'm going to say two because we have always historically focused on the blood test, the eGFR, but possibly even more important is the urine test, because that tells you there's a problem before your GFR actually falls, so before the blood test gets worse. So if we look at this, you can see we're not too shoddy at doing the blood tests, but we're absolutely terrible at doing the urine tests. So there's a massive missed opportunity to find people before their kidney function actually gets worse. So this is why the CKD workstream was really keen to look at things downstream. How can we actually do the beginning bit? How do we get people diagnosed early, and how can we get them using the test that diagnoses early? And that's the Urine ACR, and that stands for urine albumin creatinine ratio. And what that test does is it measures whether the kidneys or the filters are leaky. And if they're leaky, that's an early sign of damage, and you'll see them leaking protein in the urine. Eventually, they continue to be leaky, but then they also get scarred, and that's when the kidney function drops. So looking for leaky kidneys is a really good chance to diagnose people early. And the good thing that's happening now, and hopefully will continue to happen, is that we're now finally getting some drugs and some therapies that can slow down how quickly your kidney function declines. So there is a point to doing all these tests early now, because we can do something about it. So I'm going to show 3 slides about what the CKD workstream has focused on. And just as Lydia mentioned early, the CKD workstream is like the other workstreams, has representation from our patients, our carers, not just doctors, but also GPs and our allied healthcare professionals. So we've got, this slide is the first one, which looks about sort of a model of delivery. So how can we deliver care as an outpatient, and how can we find people virtually? Most of you know that you sadly only tend to see a nephrologist when your kidney disease is already established. So how can we provide that advice and guidance earlier on? So there was a virtual CKD conference which was delivered by the UK Kidney Association almost a year ago, where we wanted to learn about what was happening around the country before we started developing our recommendations for the ICSs and ICBs that Lydia talked about. We wanted to provide some guidance to primary care, so GPs, so that they knew how to manage patients early on before the point where they get to referral. So we've issued some guidance to the primary care and to the ICBs. And we also wanted to make sure that medicines were optimized and that we were sort of up to date, making sure that we had some digital approaches. No? My slides stopped. There we go. The other area we wanted to focus on in CKD was transition. Again, Hattie referenced this because she went through transition. She went from paediatrics to adults. And we know that this is an area where things can sometimes go wrong. And we also wanted to use it as an opportunity to try and understand, we call it the biopsychosocial model of care, but that's life. So the impact of life on the impact of a kidney disease on people's lives. So our transition group worked with the paediatric group, looking at how we could start the transition process at a time that worked for the individual. And we also wanted to make sure that their psychological well-being was monitored and then something was being done about it. So there are some tools that they've recommended in there, including as well as access to psychology. And then the social element is how can we support outside kidney disease? You know, people have education, they have jobs that they want to do. So access to youth workers and peer support. Again, Hattie's described this far better than I can. And also some national networks that they can get involved with. So we'll be producing a toolkit that we will share to integrated boards and those providers, those hospitals, to make sure that they provide access to those things for their patients who are transitioning from paediatric to adult care. And then the other area we identified as needing extra sort of transformation or support was supportive care. And this was a key part of a document produced by this group called GIRFT. So GIRFT stands for Getting It Right First Time. And what they try and do is go into different services to try and find out what changes need to be made to make sure that patients' care down the line is good. And they also identified that supportive care was an area for need. So what is that? So supportive care is, there are two types of supportive care. One is when people choose not to have things like dialysis or a kidney transplant, and they want to be able to live as well as possible for as long as their own kidneys allow them to do so. So that is what we've traditionally called conservative care. And then there are those people who are on renal replacement therapy. So they may be on dialysis and have a transplant, but perhaps things aren't going as well. And they're wondering whether they want to plan for the future in a more coordinated way that respects their wishes and what they want out for their lives and their families. So we developed a supportive care group, which is led by a specialist nurse called Karen Jenkins, or she's a nurse consultant, called Karen Jenkins, and her team is made up of people from palliative care, the community, and again, patients and carers. So they're developing some recommendations to make sure that everybody has access to good supportive care, regardless of where they are in the country. And the last thing, which is stuck at the bottom, is but is actually probably the most important one from a long-term perspective, is we want to make sure that a focus on quality improvement is embedded into one of these major clinics called the Advanced Kidney Care Clinic, because that's where most people whose kidney function is declining will go at some point. So there's a good opportunity there to make sure that we're ensuring patients have access to evidence-based stuff like early transplantation, home therapies, and choice. So we've asked for that to be a core part of advanced kidney care clinics around the country. So that gives you a very brief run through of what we've been doing from the CKD workstream perspective. And I think in the interest of time, we're going to take questions at the end. So I will pass on to my colleague, Dr. Albert Power.
Thank you very much. Thanks, Smita. So I'm Albert Power. I'm a kidney doctor in Bristol, and I lead the dialysis work stream What I'm going to try to do is just run through, focusing mainly on the key component of what we're doing in the dialysis work stream, but also talking to you about broadly what we're looking to achieve. My clicker thing isn't working, so if you just please move it on a slide, that'd be great. Thank you. Well, I think we'll just sit back first of all and just have a look at what the national trends are. We talk about renal replacement therapy. It's essentially treatment for people who have kidney failure. The optimal treatment is transplantation, and you'll see there on the graph on the left that the number of people being treated with all forms of renal replacement therapy is increasing year on year. And I would say, thankfully, this is driven predominantly by ongoing transplantation. And Nick will talk to us about the work of the transplant work stream next. If we look at the people who are treated by dialysis as opposed to transplant, we can see on the left that patients on dialysis are typically older, and actually as we move year on year, this population is aging. So there are different needs and requirements of people on dialysis, I would argue, as compared to people with a functioning transplant who on the whole, you can see there on the dark red line, are on average younger. Next slide, please. So what is the case for change for dialysis services? Why can't we just leave things as they are and continue plodding on? And Lydia's spoken in part about some of the policy changes, the introduction of integrated care systems and the NHS long-term plan. And I probably, in my simplistic doctory mind, would just envisage this really as an attempt to try to bring all strands of care into one system to avoid disruption and ensure quality. And you could argue that dialysis has rather stuck out itself on its own, a specialist service delivered by specialist units with a lot of fragmentation around elements of care. So I think we need to move with the times and see how we can improve dialysis delivery to get the most out of these new structures. And as an overarching vision for this transition is the importance to move with ongoing improvements in the quality of care that we deliver, not just the clinical quality, blood test markers, blood pressures, that sort of thing, but also patient experience of care as a key quality of marker in dialysis, improving equity of access to all forms of dialysis therapy, and I'll focus a lot on home dialysis treatments, and how we can improve value to the healthcare system as a whole so that, for example, all the money that we pay in taxes actually delivers the best benefit for patients in the long term. Next slide, please. So what about home therapies? Why the focus? Oops, sorry, that was my watch. So why the focus on home dialysis therapies? Well, we recognize that there are multiple benefits to patients treated with this form of dialysis. It's a flexible treatment that can be delivered around people's lifestyle, their weekly schedule, rather than the other way round that tends to happen with in-center hemodialysis, where actually people need to tailor their life around their dialysis treatments. In so doing, home dialysis treatments can increase autonomy, facilitate travel, both within the UK and abroad, and arguably lead to a completely different patient experience of treatment. And also because one can change the time as well as the impact of dialysis therapy on general well-being, as Simon described earlier, this sort of drained feeling, the time to recovery you get with hemodialysis. This is minimal to negligible in home treatments. It can enable people to continue in employment. But there are also benefits to the healthcare system. Of course, there's a reduced cost. Dialysis units are expensive. They're expensive to run, they're expensive to maintain, not just in terms of building, but the staffing costs associated with them, as well as the transport cost associated with taking people to and from their dialysis treatment 3 times a week. Arguably, there's a benefit in terms of medication costs. On average, people who are treated with home dialysis therapies tend to have a lower requirement for blood pressure lowering medicines, treatments for their anemia, and the dreaded phosphate binders, sort of multiple dosing regimen to try and lower dietary phosphate. And of course, because of the knock-on effects of keeping people in employment, leading fulfilling lives, you could argue that actually this is a beneficial state for GB-PLC as a whole. So if this is so great, why are we seeing this degree of variability there on the right? So this is a graph that was published in the Renal Getting It Right First Time report. Smeeta already mentioned GIRFT. And you see there the variability in uptake from centre to centre across the UK of home dialysis treatments, be it peritoneal dialysis, PD, or home hemodialysis, HHD. And great variability seen there from centre to centre. Next slide, please. So we see variability in terms of uptake. And we're also very sensitive within the work stream to whether access to home dialysis therapies is equitable. And there's been some work done by the equity team within our STP looking at home dialysis. And these are just some of the outputs. You'll see there PD rates and home therapy rates as a whole, really showing that there is a correlation between social deprivation and the uptake of home therapies. And this is a really important data metric to be able to feed back to kidney networks, integrated care systems, and say, well, what are you doing to try to address this variability that we see there? The aim of RSTP was framed by the GIRFT report, recommending that all networks, all providers are able to deliver home therapies to a minimum of 20% of all their dialysis patients. And that remains a key tenet of the home therapies subgroup within RSTP. Next slide, please. I've spoken about home therapies. That isn't the only focus of the dialysis work stream. We are looking at how we can deliver safer and durable dialysis, be it hemodialysis or peritoneal dialysis, with a key focus on access, on dialysis access, be it for hemodialysis in terms of promoting fistulas as opposed to dialysis catheters, and reducing access-related infections on hemodialysis, as well as an equivalent in PD. In other words, being able to access prompt PD catheter placement and reducing the impact that PD catheter displacement and infection can have on being able to stay on peritoneal dialysis. And the outputs of the work stream comprise of exactly what Lydia outlined. So a set of toolkits, revised service specifications to support the above, as well as data metrics to support providers and networks in ensuring that quality is maintained and improved over time. And in parallel with this, you can see that there is a separate group working through all the work streams, looking at being able to identify health inequalities and provide tools and metrics to drive change where inequity is demonstrated within our services, as well as improving the psychosocial health of patients being treated with all forms of kidney therapy. Next slide, please. So what would be the potential benefits that we would expect to see through this process in the dialysis work stream? Well, I would argue that the real aim here is to try to improve the quality of the dialysis that is delivered, but also improve quality of life for people and access to treatments that they would want to receive based on clinical advice, but really their own choice, an informed choice. And Smeeta already mentioned the importance of that, if you like, the pre-dialysis section of the patient journey, the Advanced Kidney Care Clinic, and being able to make those informed choices that fit with people's lifestyle, so they get a better experience of care. Stepping back on a wider system level, the benefits would be to allow better use of resources, managing capacity so that that doesn't impact on patient care and experience, and being able to then drive change at a system level to iron out health inequalities and continue to improve the services that we have available for patients. If you could just press again on the next slide, please. Because that would be the end state that I would envisage for the dialysis work stream, that home therapy options are effectively communicated ideally early to people, and particularly to people whose kidney function is declining and for whom preemptive transplantation or indeed a conservative approach is not appropriate. So driving to achieve that minimum of 20% and keep going on beyond that mark as appropriate. To measure and address inequity of access in dialysis therapy provision, and to have the tools to allow decision makers and commissioners to be able to make the changes that are necessary to ensure that we're doing the best that we can. Thank you. Next slide, please. That's right. And I'll hand over to Nick now.
Great, thanks, Bert and everybody. My name's Nick Torpey. I'm a transplant nephrologist at Addenbrooke's Hospital in Cambridge, and my first slide here, actually Hattie has put all of this far more eloquently than I can, as Bert has said, for many patients, transplantation is the optimal treatment for end-stage renal disease. And in the box on the left there are just some of the benefits derived from transplantation. As I say, Hattie has articulated that better than I can. I guess there are 2 points I would make. The first, that the graph on the right, which relates to the USA in the 1990s, so it's not contemporary, documents rather depressingly the risk of death for people in the general population, those with a transplant and those on dialysis. So if you're a 50 plus person like me, the bottom blue line it represents your risk of dying each year in the general population. It's about 1 in 1,000. The top line represents that risk should I be on dialysis, and that's close to 1 in 10, a very alarming difference. And the black line in the middle is the effect of transplantation. So your survival, your risk of death, the risk of death is reduced substantially, and therefore your survival enhanced. So transplantation has this one fundamental benefit for many patients compared to dialysis. The other really important point is transplantation is fantastically cheap compared to dialysis. So a year with a functioning kidney transplant is a fraction of the cost of a year of dialysis. So bearing all that in mind, the next slide is very encouraging. This is the number of people that have received a kidney transplant each year in the UK leading up to the COVID pandemic. And the white bars at the top are living donor kidney transplants, and the grey and the blue bar, which you need to add together, they're the number of people that have received a deceased donor transplant. And in 2007, there was a very important event. There was something called the Organ Task Force was established, which was chaired by Dame Elizabeth Buggins, who I think many listening will be familiar with. And that produced a report, Organs for Transplantation. And the challenge in that report was to double the number of deceased donor organs over the next 10 years. So the first year after that report was in 2009, and there were 1,400 deceased donor kidney transplants. Expressed 10 years to pre-COVID, well, we've almost achieved that ask. There were more than 2,400 deceased donor transplants. And the sustained increase in deceased donor transplantation has been hardwired, if you like, by further strategy documents from NHS Blood and Transplant. And the really encouraging endpoint of all of this is that if you were waiting for a kidney transplant in 2010, the average wait was more than 3 years. If you're waiting for a deceased donor kidney transplant now in the UK, the average waiting time is less than 2 years. In fact, it's 570 days. So the waiting time has more than halved. There have been other important developments as well. Oh yes. So in 2019, the way that kidneys were allocated was changed to improve equity, and I'm going to come back to that point. The following year, in 2020, the law changed to promote to create the opt-out system for donation, which you heard about earlier. And then during the COVID pandemic, there were two important documents. The first is the GIRFT report that you've heard, and the second is the updated NHS blood and transplant strategy through to 2030. Both of those documents emphasized both the tremendous achievements over the last 10 or 15 years, but also that we shouldn't be complacent. And on the right there is a sort of table elaborating the ambition of the 2030 strategy. And everything I've talked about up to now is on the left-hand side, the donation side. On the right-hand side, the transplantation side, there are clearly areas that we need to improve, and they were highlighted very much by the GIRFT report. And I'm going to give you just 3 examples. So the first is that depending where you live in the country, the probability that you would be assessed and listed for a kidney transplant before you need dialysis is very variable. So in some parts of the country, it may be only 10 or 11% of patients are preemptively listed. In other parts, up to 50%. The second example is that although waiting times have improved enormously, there is still variation. So the best is the wrong word. The centres with the shortest waiting time have an average waiting time from listing to transplant of maybe 300 days, and the longest waiting time 700 days. So that's a vast improvement from the past, but there's still variation. And the third thing is that patients from either Black or Asian ethnic backgrounds we know are much more likely to develop kidney disease, but their access to transplantation is less. So it takes longer to be listed. When you are listed, you're less likely to be offered a transplant. The thing on the left is I guess, documenting all of those things in the RSTP format that you've heard about already that I won't talk about. And from those 3 examples I've given, I think you can see that the key focus of the transplantation bit of the RSTP is on the first bit of the pathway. So identifying, assessing and waitlisting patients in an equitable fashion, preferably before you start dialysis, so that everyone has an equal opportunity to be offered a kidney. And that was very much emphasized by the GIRFT document, and the three key highlights are listed there on the right. I'd include a fourth, which is that all of these activities need to be properly commissioned. So that is to say, the people delivering the care are funded to deliver the care. So in the RSTP transplant program, we have groups working on all the 4 things listed on the left there. So as I've talked about already, assessment for deceased and living donor transplantation, management on the waiting list. Then there's the whole business of receiving a transplant in a hospital and follow-up. So we've identified the things we need to focus on. We've identified how we need to focus on them. That's the service specification that you've already heard about. And the challenge now is, how do you embed that into clinical practice? So how do you commission services to deliver all of these improvements? And Lydia's touched on the fact that the way we deliver services is changing, and transplantation in particular is challenged by quite significant changes that are happening in NHS commissioning. So I'm going to stop there. I think I'm going to hand back to Lydia to sum up.
Thanks, Nick. Thanks to all my colleagues. So in terms of what to expect next, sorry, if you could just go back a slide. Still having trouble with my clicker.
That wasn't me.
Oh, to the 2023 slide. Thank you. Thanks very much. So in terms of what to expect next, so we are anticipating that we'll see the following being rolled out in 2023. So we'll have the updated service specification. So we've mentioned those on several occasions through the presentation. That'll outline the best practice that are being produced by my clinical colleagues across their work streams. We will have the Renal Services Clinical Reference Group, and we will have a new Renal National Clinical Director, a really exciting post for renal services in England that's just been reintroduced. And that new Renal Services National Clinical Director will manage both the clinical reference group and also provide clinical leadership for the Renal Transformation Services programme. So that role will pull all of this together, which will be critical to delivery of the transformation programme in the future. We'll have regional accountable networks, and as I mentioned, we've established renal networks across England, and their primary focus is to deliver the outputs of the Renal Transformation Services programme. They've got high impact changes that they're working towards delivering across all of the regions in England that focus on quality improvement initiatives. And finally, we'll have the toolkits and the renal dashboard that detail quality and patient experience metrics to support decision making. So there's so much coming out of the programme, and we anticipate it really will improve renal patient care of the future. Thank you very much.
Oh, thank you very much. Thank you. Very interesting talk, and great to hear improvements coming our way. A couple of questions before we go to the break. Are the toolkits in the public domain?
I'll look to my colleagues for some support, but I'll take that question. So the toolkits at the moment are still in development. So we're anticipating they will be available, as we say, in 2023. The toolkits will form part of the overall service specification, and all NHS England service specifications are available in the public domain on our web pages.
Right, another question. How will you deal with the services which cut across more than one ICS but are not national?
So really great question, thank you. So as I mentioned, at the moment, we are, NHS England have a number of groups that have been established to look at how we can best support integrated care services to manage the care pathways. But what integrated care services will do is work together to make sure that if there are crossover of care or services that involve multiple ICS platforms, they will work together to ensure that there's seamless access to care for patients, and that will be the expectation of NHS England.
Another question, this would be interesting. Is there any consideration for introducing bio-artificial kidneys into the NHS?
Shall I? I guess you mean as an alternative to a kidney transplant. So bioengineering organs for transplantation is very challenging. Probably the most advanced the area that's most advanced is heart transplantation, because the heart is is basically just a muscle with some electrical wiring going into it, and so that's quite easy to regenerate. The kidney, unfortunately, is spectacularly complicated. There are lots of different cell types that make up the kidney, all of which need to interact together. So I think the probability that we will be able to bioengineer a functioning kidney for transplantation in our lifetime is negligible. I think the area that is likely to attract much more attention is xenotransplantation, and some of you may have seen some sort of headline events in the USA where pig kidneys have been transplanted, and in fact a pig heart into people, and that's something perhaps to watch out for in the next 10 or 20 years.
Brilliant, thank you. Ladies and gentlemen, thank you very much for that very interesting talk. Everyone wants to put the kettles on, so we're going to take a break now for 10 minutes. When we come back, we're going to be looking at dialysis decision making. So let's look at our watches. We'll come back at 12 o'clock. If you leave your feeds on, we'll just return in a little while. Thank you.
Thank you.
Ladies and gentlemen, welcome back. So our next speaker is looking at dialysis decision making and the experience of BAME patients. Welcome, Dr. Kerry Rosenberg.
Okay, thank you so much. Good afternoon. My name's Kerry Rosenberg. I'm a renal registrar at the Royal Free Hospital in North London and have an academic appointment with University College London. I'm going to be talking today about dialysis decision-making in elderly patients with advanced chronic kidney disease, and particularly amongst those from ethnic minority groups. So I'm going to be starting by talking a little bit about the diversity of our UK renal population. So these numbers are taken from the UK Renal Registry report, which was published last year and covers data up until the end of 2019. So as of the 31st of December 2019, there were just over 68,000 patients receiving renal replacement therapy for end-stage kidney disease in the UK. Of those, 13% were Asian, 8% were Black, and 3.1% came from other ethnic minority groups. Of course, there's lots of geographic variation. So in our London centres, and particularly at the Royal Free, 22% of our population are Asian, 22% are Black, and 10% come from other ethnic minority groups. And those percentages are pretty similar across the London centres, so quite a lot more diverse. What's particularly important to mention is that we know we've got good evidence that our Black and Asian patients are at increased risk, both of progression of their kidney disease and of development of end-stage kidney disease and needing to start dialysis. So given that we know that our ethnic minority patients are overrepresented in the population, it's no wonder that there's growing interest and concern, both from clinicians and from researchers, as to addressing health inequalities in the population and what might be able to be done about that. Health inequalities in general are becoming more prevalent in the public consciousness, and that's mainly because they've generated lots of media attention recently. These are just a few examples, but these are all headlines which have been in The Guardian and the New York Times over the last 18 months or so, addressing this question about racial inequality in healthcare all over the world. And it's not just amongst the media that these conversations are happening. It's been at the forefront of the minds of health researchers as well. So this quote is taken from a review article that was published in BMC Nephrology back in 2019. This group of researchers looked particularly at kidney patients and the whole kidney patient journey, and they sought to collate all of the information, all of the research that we have about health inequalities in kidney care. This quote is included in their conclusion, and I think it's really important because it highlights that there's a number of points in the kidney patient journey, from access to kidney clinics, transplants, care on dialysis, where there are health inequalities, and that means there are lots of targets for research that could drive both practice change and policy change. Now, the bit of the kidney patient journey that I'm particularly interested in is something called supportive kidney care. And depending on where you're looked after, you may have heard this referred to as conservative care or perhaps as maximal conservative management. That all means the same thing, just different terms. Supportive care is defined as a planned and holistic approach to the treatment of end-stage kidney disease. It includes things like psychosocial support and advanced care planning, as well as the active management of the symptoms and complications of kidney disease, but without dialysis. So why is this important? There's been quite a lot of work that's gone into supportive care in the last few years, and these numbers are taken from a systematic review that was published last year, 2021. They included all of the current papers looking at survival for patients on dialysis versus survival for those who chose the supportive care or conservative care pathway. And the mean age of the patients included in all these studies was 60 to 92, so a reasonable range. What they found was that for older patients starting on dialysis, the survival benefit was actually quite small. 73% were alive at 1 year on dialysis versus 71% who chose conservative care. Now, it's important to say that in the second year, this disparity rose quite a lot. So at year 2, 62% of those choosing dialysis will still be alive versus 44% for those choosing conservative care. And remembering that we're talking particularly about older patients here. Now, what's key to understanding this data is that for those patients who are more frail, who have more health problems, this small survival benefit is actually substantially reduced. In addition to that, we know both anecdotally from our patients' experience and from a body of evidence that dialysis can be a burdensome treatment. And so effective quality of life is an important part of that decision as to what treatment pathway a patient is going to have. So all of that's to say that for some patients, supportive care may offer a treatment option that's better placed to serve the values and priorities that are important for that particular person. Now, we know that dialysis decision-making is complex. There are patient, clinician, and systems-related factors all in an interplay. And it's a balance between what's medically advisable and what's important to that particular patient. These are complex, nuanced discussions. There's been a fair amount of work that's gone into looking at things like shared decision-making and what people prioritize when they make their treatment decisions. But actually work looking at the particular experience of our ethnic minority patients is missing, and there's a real gap in our knowledge. So looking at what we know so far, as I said before, there's a real gap in our knowledge when it comes to looking particularly at dialysis decision-making, and even more so when it comes to looking at those decisions in our ethnic minority patients. There's some work in the US, small qualitative studies mainly, which has looked at things like advanced care planning and access to palliative care and things like dialysis withdrawal. But the question of whether people choose to have dialysis or not is something that's missing. And again, these are all the American studies that may be less relevant to us here in the UK. But there are some important themes that have come out of that work that we may be able to extrapolate to the question of dialysis decision-making. So, coming to the slide then, on the right-hand side is a study from 2018, which looked at just over 1 million dialysis patients in America and their choices. What they found was that in comparison to white patients, patients from ethnic minority groups were less likely to discontinue dialysis at end of life. They were less likely to die in a hospice setting, and they were less likely to die in a non-hospital setting, for example, at home or in a nursing home. And this was true for the minority patients as a whole, as well as for individual groups. Also, this difference persisted after adjusting for other factors like income level, age of the patients, and the type of insurance they had. On the right of your screen, you've got an older paper. This is from 2010, so it's a little while ago, but I still think it's relevant. And this is a piece of qualitative research. It included 61 patients, again, dialysis patients from a US centre. And what the researchers did was ask them if they would hypothetically consider stopping dialysis in a number of different health states. For example, if they had a stroke, if they were diagnosed with dementia, or if they were in a coma. And what they found was persistently, Black patients were less likely to support stopping dialysis, regardless of health state. Again, this persisted after adjustment for other factors like age, level of education, and comorbidities. So what we can see here is a clear difference in perspective, as well as an access to robust palliative care planning. But what we can't begin to understand from these studies is why these differences exist. Just skip ahead a little bit and talk a little bit more about some of the studies that have been done so far. Again, looking at small qualitative studies and with the caveats that these have all been done in a US-based population and didn't include any patients who were non-English speaking. So looking at a very particular subset. There's a paper in JASON in 2021, which performed structured interviews with both patients, caregivers, and their doctors, and found that amongst clinicians, there was a discomfort and a reticence to initiate advanced care planning discussions with patients from ethnic minority groups. And when asked about why that was, they cited feeling that they assumed that those patients would take offence or not want to engage in those conversations. And there were also additional communications and cultural barriers which hindered those conversations. This is borne out in a larger piece of work which looked at 5.2 million inpatient admissions for people with a diagnosis of kidney disease. So this could be admission for another reason, but with a coexisting diagnosis of a kidney problem. And what they found was that ethnic minority patients were consistently less likely to be referred for a palliative care review during their time in hospital than their white counterparts. So looking at all of this, it's in no way meant to cast judgment on the preference to continue treatment or the preference for more aggressive treatment. But there's certainly a difference in perspective, and I think that's an interesting thing to explore. What I think we don't understand is whether that is just personal preference, whether it reflects a cultural belief, a religious belief, or whether it reflects a distrust in the medical community that means people feel unable to access those services. Or are we as medics not providing those more vulnerable groups with the information and the options that they need to make treatment decisions? All of that to say, from the work we've got so far, I think we could hypothesize that access to supportive care would be more challenging for patients from ethnic minority groups, and that conversations about whether to have dialysis or not may be more complex and more challenging. This brings me on to my work at the Royal Free, so looking at our local population here in North London. And I set out to do 4 things with this work. The first was to describe the social and clinical demographics of a group of patients with advanced kidney disease as it related to what they chose as treatment. Secondly, to take those factors and to identify the predictors for who would want to have a supportive care treatment pathway. I then went on to look at the time taken to reach a treatment decision. And I want to talk a little bit about why this outcome was taken. So obviously, taking time to make a decision for anything, whether it be for supportive care or else, is not necessarily a bad thing. However, it may be a useful marker of how challenging that conversation is, how much deliberation is needed to come to a conclusion. And actually, when it comes to choosing to have a supportive care pathway, for some patients for whom dialysis might be medically inadvisable, those people who are more unwell and more frail, actually making a decision timeously might be really important. Because as we've said before, supportive care pathways offer this extra bubble of support from people like palliative care nurses and home support that might be really important for someone who's in their final months of life. And so we want to get them onto that as quickly as possible. Finally, I wanted to look at the success, quote unquote, of treatment decision-making amongst this group of elderly patients. And that's a really difficult, if not impossible, thing to measure, because what's the right decision for one person is not going to be the right one for another one. It's extremely personal, and a large part of that is driven by what's important to that particular patient. What we can measure, though, are objectively poor clinical outcomes that may tell us something about how that treatment decision has worked for that patient, whether it's truly serving them. And I'll come to talk a little bit more about that shortly. So, moving on to how this project was carried out. Data was pulled from the electronic patient record at the Royal Free. I included all patients over 65 years of age who had a new low clearance or supportive care modality recorded in their records between the 1st of January 2015 and the 31st of December 2019. So a 5-year period, particularly stopped in 2019 because, as we all remember, clinics and care pathways were disrupted in 2020. Data was collected for each of those patients. This included their age, sex, and the cause of their renal disease, and then their comorbidities. The ones we focused on particularly were a diagnosis of cancer, dementia, cardiovascular disease, or diabetes. We then recorded ethnic groups for each patient and recorded IMD deciles. So IMD stands for Index of Multiple Deprivations. It's a measure of social deprivation. Every postcode in the UK will be assigned to one of 10 deciles. The most wealthy, affluent postcodes in the country are decile 10. The most socially deprived are in decile 1. So from each person's postcode, we were able to generate an IMD decile, and that was used as a marker of socioeconomic status. I then recorded whether patients used an interpreter or not. That could be informally with family members, interpreting in consultations, or formally via the interpretation service. And finally, whether they reported a religious affiliation in their notes or not. We also reported frailty scores at baseline on entrance into low clearance as they changed over time. So this is something called the Rockwood Clinical Frailty Scale. It's used internationally. The score is assigned by the clinician when they meet the patient, and it's an objective marker of how frail that particular person is. Finally, we included GFR, or percentage of kidney function, as it changed over time. All of these patients were then divided into 4 groups according to their outcome in the low clearance clinic. So lots of numbers on the slide, but I'm going to pull you towards some key things. There were 1,768 patients included in the study, so a good number. And as I say, they were divided into 4 groups. So those who chose supportive care, it's 515 patients. Those who chose to have kidney replacement therapy, so received a transplant or started dialysis, 309 patients. Those who died before a treatment decision was made, that's 189 patients. And those who remained in the low clearance clinic or were discharged, and that's mainly people whose kidney function was stable and no further action was needed. And then we looked at the demographics of these 4 groups, which is those descriptive statistics I was talking about. As we can see, the supportive care group tended to be older than those who chose dialysis, which is expected, mean age of 82 versus 73. More female patients chose supportive care versus kidney replacement therapy. More males chose to have kidney replacement therapy, which was actually an expected outcome. When it came to ethnicity, 29% of white patients chose supportive care versus 24% of Black patients and 28% of South Asians. Looking at the raw numbers, it looks like there's a smaller percentage of Black patients who are choosing supportive care, but actually that probably reflects they are a slightly younger demographic, and overall their mean age was slightly lower than those in the white patient group. And finally, coming to IMD decile, again, the supportive care group have a slightly higher IMD decile, slightly less deprived, with an IMD of 5.3 versus 4.9 in the kidney replacement therapy group. But actually, the statistical difference between those groups was not significant. Moving on to a few more numbers, as expected, those who chose supportive care tended to be more frail than those who chose kidney replacement therapy. And there was no statistically significant difference between the groups as to who was religious or who used an interpreter. Our second goal was to identify factors that were predictive for choosing supportive care. So for this, I used a logistic regression model. What that means is that each exposure, for example, ethnicity, IMD decile, frailty score, were modeled against age, sex, and comorbidities to give a chance of how much that would cause you to choose supportive care. So there's the suggestion, looking at the raw numbers, that fewer Black patients chose supportive care, but actually that normalised completely with age and probably just reflects the fact that the Black patients were slightly younger than their counterparts in the white group. IMD decile, whether people used an interpreter or not, and whether they had a religious affiliation or not, actually made no difference to what they chose. So what did make a difference? The major predictor for who chose supportive care and who didn't were really clinical factors rather than socioeconomic, and they were age, frailty score, and dementia. So those who were older, had higher frailty scores or a diagnosis of dementia were more likely to choose supportive care than anyone else. And that's, again, not an unexpected outcome. What is unexpected, I think, is that ethnicity and IMD decile had no effect. So moving on then to time taken to make a decision to have supportive care. For this, we used a Cox regression model. Who made decisions more quickly? Again, it was clinical factors. Older patients, those with higher frailty scores, those with the diagnosis of cardiovascular disease or dementia, all made a decision more quickly than other people. When it came to ethnicities, the only real difference we saw was in that group of other ethnic minorities who tended to make decisions more quickly. That's a difficult thing to interpret because that group in itself is so heterogeneous. There's patients from lots and lots of different backgrounds. Within the other groups, ethnicity made no difference to what they chose. Male patients tended to make decisions more slowly. They were also much less likely to choose supportive care at all. And that's actually not a surprising finding. That's borne out in lots of the palliative care literature, which suggests that female patients are more likely to choose conservative treatment over more aggressive treatment. IMD decile made no difference, the time taken to reach decision, and likewise religion and interpreters made no difference. Moving on to the final part of this, which was looking at markers for an unsuccessful or challenging decision-making process. As I said before, that's a really difficult thing to measure, which is why we were looking at objective clinical outcomes that may demonstrate that a certain treatment decision is not best serving that particular patient, or that the decision process has been challenging. So the first thing we looked at were risk factors for dying in the low clearance clinic before a decision was made, or within 3 months of starting dialysis. Now, the first part of that was chosen because the rationale for it was that if you are someone who is frail, elderly, lots of medical comorbidities, who's in the low clearance service, perhaps someone for whom dialysis is not medically advisable, someone who's approaching the final months of their life, we want that patient to be counselled to make a decision that's right for them and to start a supportive care pathway as quickly as possible, or if dialysis is important for them, to commit to that. But what we don't want is that person dying in the low clearance clinic without the extra bubble of support that's offered by a supportive care pathway. The second part of that, dying within 3 months of starting dialysis, is a bit more intuitive. Of course, we want our patients who start renal replacement therapy to do well. We want it to improve their quality of life. Dying within 3 months of starting is not ideal. So this graph just shows the effect of ethnicity on that outcome. And as you can see, there's very little difference between the groups. And actually, ethnicity was not a factor, and neither was IMD decile. Again, the factors that affect this are those clinical things: age, frailty, and comorbidities. Which brings me to the final part of this, which is again a measure of the success of treatment decision-making. For this, we used time spent in a hospital as a marker of increasing morbidity and frailty. So what we did was look at emergency admissions only, but time spent in hospital in each of the 3 groups. So those in supportive care, those in kidney replacement therapy, and those still in the low clearance clinic. Those with supportive care pathway spend much less time in hospital than anyone else. That makes sense. That is the point of supportive care. Those in kidney replacement therapy spend more time in hospital than anyone else. The interesting bit was looking at the effect of ethnicity in each of those groups, and actually that had no effect on the time spent in hospital with whatever you chose. However, patients from lower IMD deciles spent more time in hospital once started on dialysis, and this was not true in the supportive care or low clearance groups. So that might tell us something about the morbidity of those lower socioeconomic groups, those patients when they start on dialysis, and it might suggest something about their suitability for the treatment and the decision making they've been through. Finally, coming to a few conclusions. The factors associated with choosing supportive care and the time taken to make that decision are in fact clinical rather than socioeconomic, which I think was an unexpected finding for us. What we can say from this population, at least, and it may not be generalizable, that ethnicity was not a risk factor for unsuccessful decision-making or poor outcomes once established on kidney replacement therapy. However, there is that suggestion that lower socioeconomic status may be associated with increased morbidity in patients established on kidney replacement therapy. And that brings us to a really important conclusion that ethnicity can't be viewed in a vacuum. It's about the wider socioeconomic context, social deprivation, who the patient lives with, and their home setup, education, religious and cultural beliefs, all of those factors that make a person who they are and define the choices they may make and what's important to them. The study is important because it's the first of its kind to look specifically at dialysis decision-making in a UK-based cohort, and specifically to focus on the socioeconomic factors that may affect those outcomes. It's a fairly large cohort and certainly adds to the data in that way. However, it's important to say that it's limited by its retrospective design, which means looking back in time. And it's also important to say this is a single centre study which took place within a tertiary centre in a very diverse urban community, and it's certainly not generalisable to the UK as a whole or internationally. So what's needed really to add to our knowledge, and I don't think we've answered this question yet, of dialysis decision making in our ethnic minority patients, is multi-centre or national data looking at who has supportive care, what the barriers to access are, and those markers of challenging decision making on a much larger scale. I think the next thing to say is that, as I've said time and time again over the course of the last 30 minutes, is that this is complex and a nuanced discussion between patient and doctor, and therefore the patient experience really has to be front of mind. So having said all of that, I'm hoping to take this work further. I'm hoping to take it towards a PhD, and what that will involve is that big data section looking at what happens to patients across the country in their dialysis decision-making journey. But also what I'd like to do is look at a smaller, more focused piece of qualitative work, which looks at the patient experience of those now more vulnerable patient groups, those from ethnic minorities, those from lower socioeconomic groups, those who don't speak English, and what their experience is like. Fine. I'd like to finish just by thanking my supervisors at the Royal Free. It's Ben Kaplan and Anya Burns. I've left my email address there. That's my UCL email. I'd be delighted to hear from any patients who would like to discuss further, have any questions, or would like to be involved in conversations in the future. And I hope there'll be some questions and comments. Thank you so much.
Yes, thank you very much, Kerry. We just have one question, actually. Do you know about the availability and supportive care programs for ESKD patients? Hopefully that.
Yeah, so end-stage kidney disease. Yeah, so that's really what supportive care is. It's providing, as I said, treatment for those patients who have a diagnosis of end-stage kidney disease, who would otherwise have dialysis, but for whom it is either not in line with what they personally want to have or not medically advisable. But all renal units around the country will offer supportive care, and there will be availability, the sort of the setup, the resources available, whether they are specialist nurses and that sort of thing, will vary by units, but it is becoming more and more of a focus across the country, and particularly here in London, there is now a supportive care working group looking to make sure that we standardise treatment for those patients and help people to access that.
Thank you very much for your time today.
No worries. Thank you very much.
We move on to the next speaker, and we can't escape the day without talking or reflecting on the COVID pandemic. So let's hear more.
Thank you very much for this invitation to talk on COVID-19 with regards to our experience at Eastern North Hearts. I was going to talk about the renal care in a pandemic versus endemic and the lessons learned, but I changed a little bit to talk about what our experience was locally at the Eastern North Hearts itself. I've got no disclosures. What I would talk about is our local experience and try to show the amount of teamwork and the multidisciplinary involvement that was involved in looking after our patients. Not everyone may be mentioned, but grateful for the trust, Eastern North Hearts, and the East of England network for its support it provided to get us through this pandemic. Just to give a little bit of an overview of what we do, we care for patients in Hertfordshire, Bedfordshire, and West Essex. We have a hub and spoke model covering 4 acute NHS trusts. The population in our catchment area is about 1.5 million people, and we look after people with acute kidney injury, chronic kidney disease, autoimmune conditions, and people who need renal replacement therapy, usually dialysis, transplantation, and supportive care. Our acute transplantation happens in 3 different centres. One is Addenbrooke's in Cambridge, the Royal Free in London, and the West London Renal Unit. Even pre-pandemic, renal replacement therapy needs were increasing over the years. From 2015 up to 2022, you can see growth keeps happening for people with end-stage renal failure needing renal replacement therapy, be it with in-center dialysis, home dialysis, PD, and transplant. This is all our local data, and it's reflected nationally as well. So despite a pandemic where there was high mortality and morbidity, renal failure continues to grow, and we need to provide the best service we can for these group of patients. Our catchment area is quite large. We are spread out from the south, just above the M25, all the way up to Bedfordshire, and we go from west to east, from Hemel Hempstead all the way down towards Harlow and the Chelmsford area. So we've got a large geographical area. Our infrastructure for dialysis was not as good as it is at the moment. We had an acute dialysis unit of 5 beds, a renal ward of 21 beds. We had 10 out of 50% of our critical care was plumbed for dialysis, and we had a Lister main dialysis unit with 24 stations. We also had 4 satellite units, one at the Luton Dunstable Hospital, one at the St Albans City Hospital, and then we had an offside renal unit on Bedford and one in the Princess Alexandra Hospital, with each one having a different number of stations of the capacity for patients. So early in 2020, the unknown happened. COVID-19 was spreading worldwide. We didn't know what it was going to do. Should we worry? And a lot of people had fear, fear for themselves, fear for family, friends, colleagues, patients, and what would happen next as we progressed through that year. What we did realize was that we had to start planning and thinking about how COVID-19 may affect our patient group. And the patient group we worried about was our in-center dialysis group. We did models, and it showed that without any major intervention, 80% of our dialysis patients would get infected. So we have the most vulnerable group, one of the most vulnerable groups of patients in a healthcare setting. Patients need to come for their treatment. It's life-saving treatment for them. They have to come for their dialysis, or they need to come for their urgent procedures and treatments, which could be renal access surgery, investigations such as kidney biopsies, and have chemotherapy treatment for them. So these patients couldn't isolate, or they couldn't stay at home during lockdown periods. They had to come out into the communities and into hospitals where there's potential risk of exposure to COVID-19 and becoming unwell from it. So we had to operationalize what we did to protect our patient groups. So with senior management, we started a daily COVID-19 management group in the renal department, led by the clinical director and by the renal head of nursing. We increased our out-hour covers for renal senior cover for 7 days a week. And we had a pandemic medical rota. This was to support critical care. It was to increase the renal bed base for the expected increase of renal failure and to support acute medical admissions. We had to redistribute our workforce into different areas and different professions to help across what was going to be a very difficult time in the country. But what we realized quite early on, that infection prevention and control was probably the single most important measure. And even prior to government advice, we realized that patients needed to reduce their exposure by coming out of the community. They needed to shield. Face masks became a priority, and we implemented that across all our dialysis units quite early on before it became mandatory nationally. We used standard PPE, and we encouraged patients to self-transport to avoid exposing themselves in patient transport services. We started temperature and symptom screening as well. So we had to think about how could we reduce transmission? What were the other aspects we could do? Could we thought increasing of social distancing was probably one of the key aspects, and increasing our isolation capacity to dialyze patients, to dialyze if they were infected or suspected of being infected, away from the general dialysis population. So we did a few things. So to reduce or increase social distancing, one of the things we did quite early on was to try to reduce our patients from 3 times a week dialysis to twice a week dialysis. This will reduce their overall exposure risk in the community or in hospital settings to COVID-19. Incremental dialysis is a part of our unit culture. We measure residual renal function monthly, so we were able to identify patients who could manage for short periods of time from 3 times a week going down to twice a week. And during the peak of the pandemic, our proportion of patients who dialyzed twice a week increased from 8 to 10% up to nearly 30%. We also freed up isolation capacity through the review of patient isolation requirements to try to ensure we had the right patients in the right areas. We reschedule appointments across the day to improve the gap of time between dialysis shifts to allow patients not to cross over and increase the risk of transmission between shifts of dialysis. We cleared an evening shift initially in the main unit in case we had COVID positive patients to dialyze them in isolation in the evening. And we even had plans in place to open up dialysis units at night and to do night dialysis to avoid patients who may be infected with COVID-19 from dialyzing with the general population. Then we also thought of creating a COVID unit, but logistically that is extremely difficult when you have very high capacity of patients. So our stations are used at 99% capacity. There's barely any give in the way to move patients around to create a whole COVID unit. We looked at cohorting patients in bays and shifts according to their postcodes, because if there's an increased incidence related to a postcode, those patients then would be in the same region and the risk would be the same as where they lived. And the main thing which helped us get through the COVID-19 pandemic is actually sourcing an isolation facility. So what we did was, we called it the Florence unit. What we did was we actually craned in porta cabins in the front of the hospital, which were all connected together, and made side rooms or isolation rooms for dialysis in this built porta cabin area. We plumbed it with water. We kitted it out with dialysis chairs, IPC equipment, separate dialysis machines, and we delivered dialysis in isolation for patients who were suspected to have COVID-19 or had COVID-19 who were well enough and not need to be in hospital. Sorry, so this is just a few pictures to show how it worked. We had a nursing station in the middle. We had 8 dialysis side rooms, which provided one side to be suspected patients and another side to be patients who are already COVID-19 positive. And I think without this, with our infrastructure at East and North Hearts, we wouldn't have got through the pandemic. Another thing that happened during the pandemic is the recognition of increased acute kidney injury requiring renal replacement therapy and multi-organ failure of patients with COVID-19. There was this worry, and there was a lack of materials to provide hemofiltration on critical care units. So they were not able to get kits or the fluid to provide renal replacement therapy for critically ill patients on critical care. So we had to improve our infrastructure to allow us to use alternative ways to provide renal replacement therapy on our critical care areas. So what we did is we put in water equipment were installed, we put water plants, we put water rings into all our critical care areas, including and augmented new critical care areas in our trust to deal with the pandemic. And this allowed us to provide hemodialysis in all critical care beds. And these are with the team and the nursing team who went in and out to the COVID-19 areas to provide hemodialysis for our patients who are on critical care, as well as we also developed a protocol for very gentle, slow, low efficient dialysis on critical care for more patients who are more unstable with multi-organ failure. This was called SLED-F. So we successfully collaborated with the critical care to implement this, and this saved hemofiltration resources when there were high demands during the pandemic. This is kind of a summary of the major infrastructural changes we did. Our isolation dialysis unit, where its peak was dialyzing 52 patients without having to activate further renal surge plans. We increased our dialysis infrastructure in hospital, while critical care went from 10 to 32 spaces on the critical care which could provide dialysis. And we increased our ward areas to be able to provide bedside dialysis by nearly 50%. And we became a regional referral center to manage COVID-19 patients with end-stage renal failure and acute kidney injury. So another thing that was important during the pandemic was to look at transport and how we could reduce the risk to patients that they could be transmitting infections, getting cross-infections in transport. So the simplest ways were if patients were able to self-transport, if friends or family within the same social bubbles could transport them. We got named volunteer drivers for named patients, so they had the same volunteer driver who would drive them in for dialysis. And we worked closely with the patient transport service to develop relationships, links, and more efficient transport services for renal patients. During the pandemic, the demand for patient transport had gone down due to less outpatient activity in other specialties, which meant that actually we could prioritize renal transport. Now, post-pandemic, renal transport has gone back to pre-pandemic levels, but we are working closely with the patient transport service to improve this, because it's one of the key aspects, I think, to the patient experience when they come from dialysis. Now, home therapies is a very important area which actually protected patients. So patients who did not have to come in to hospital 3 times a week and do their treatments at home were less likely to get infections. So patients who were on PD or home hemodialysis, it really protected them. So we carried on doing home dialysis training, except during peak times where staff had to be redeployed to manage in-center areas. And the reason we carried on home therapies was to keep having patients to continue their home dialysis. And over the first year, we managed to still have 50 new patients go onto a home dialysis program. Transplantation continued during the pandemic. Addenbrooke's was one of the few centers nationally to remain open for transplantation during the pandemic. And in that year, we had a good year still with 67 patients who were transplanted. Unfortunately, transplant workup for patients who are on renal replacement therapy had to be put on hold because we did not have the staffing, and we had to redeploy the staff to help out with other critical areas. Now, dialysis is one aspect, but there are other aspects where we support patients, our transplant patients, our patients with advanced kidney care patients. So they were isolating, but they still needed to be monitored and managed and have a variety of different aspects of the care delivered. Bringing them to face-to-face clinics did increase their risk, sitting in large groups. So we introduced lots of virtual working to try to support the patients in the community. But we did have key patients or patients who needed face-to-face reviews to be reviewed in our green sites, as we call them. So sites which are not on acute trusts, sites where they were less likely to come to unwell people who may have COVID-19. We introduced virtual home visits for via the renal support team and advanced kidney care team. And we also had dedicated phlebotomy and vaccination clinics for our advanced kidney care patients. So this took them away from the general population coming in for a variety of different tests and investigations and reducing their risk. In terms of pharmacy, we started a service where we could deliver drugs out to patients. So any changes we made for patients, we delivered the drugs out to them. They didn't have to come out to get them. And this included things such as erythropoietin and immunosuppressive medications. Now, this is just a picture of the team working at the desk, working hard to try to communicate with patients and each other and trying to help provide a virtual service, and a variety of different comments from patients who found it very useful. It saved them time in terms of driving, it saved them parking. So I think virtual working is extremely important in the long term, and we should keep it going. But there will be patients that we need to see physically because you cannot gain the same level of care and rapport over phone sometimes. I would like to talk about our renal support team. So during the pandemic, there was an increased number of social referrals. Patients had financial difficulties, loss of employment, housing issues, anxiety. Our social workers were proactive in contacting all COVID positive patients and family, and our counseling service as well in contacting the bereaved who may or may not have had COVID as well. And what we found was that this is a very much appreciated service during the pandemic. And we found that actually during the pandemic, despite other areas reducing the amount of outpatient activity, our outpatient activity actually increased, showing the increased support we provided for our group of patients. Another important aspect during the pandemic was screening of our patients in the dialysis units. What we did know, there were quite a few patients who were asymptomatic, so they may have had the infection but not had any symptoms, and by being in the general population, they would end up transmitting it to other patients who potentially could become unwell. When we had an increased incidence of COVID-19 quite early on in one of our units, we started a screening program. And once we started the screening program, finding asymptomatic patients and taking them out of the patient group, so isolating and dialyzing them, resulted in less new infections happening in the unit. So since then, we've implemented asymptomatic screening in all our dialysis units, and staff have been doing lateral flow testing twice a week. Vaccination, and majority of people will know about vaccination and how vaccination has turned the tide and protected the community and the people from this virus. We found that quite early on, we were believers in vaccination, and we took days out in the week to book a whole vaccination hub, so our own hub at the Eastern North Hearts Lister Hospital, where we went out and got 400 over patients to be vaccinated because we felt this was an important aspect of their care and protection for them. So over that first year, a variety of different things happened. We had a large amount of input to our patient groups. What I really wanted to show was in terms of a benefits advisor. So a lot of people did go through hardships. The support that we had with the specialist benefit advisor during that time allowed nearly £400,000 worth of benefits to be secured for patients who needed it. And I think this is extremely welcomed in the patient group. And there's a few comments here for how they felt with the support that they had. Another aspect that came on end of last year was about COVID extended therapy. So these are treatments given to patients who early on in the infection who are high risk to becoming unwell. These drugs reduce the risk of the patients needing hospital admission. We work closely with the local CMDUs. These are the hubs which deliver these medications, and we collaborated with them to be able to provide the treatments to our renal transplant patients and our dialysis patients. And we deliver these treatments either in the dialysis unit or in the local CMDUs. One thing which I'm quite proud of the team, despite a pandemic, we still had to help patients who are in an extremely difficult situation. This is a patient who had a total artificial heart. This is during wave 3 of the pandemic. He was an inpatient at the Hatfield Hospital for 3 months, and he was deemed unfit for hemodialysis as an outpatient. Our home therapies team went, saw him, reviewed him there. They worked closely with the Hatfield team, the cardiology team out there, and we started a program of training him for home hemodialysis on one of our main dialysis units till him and his family were able to do it, and he had 6 months at home having outpatient dialysis. Without this, his life would have been shortened and he wouldn't have had the time to spend with his family. So despite a pandemic, there are quite a lot of innovative things that we can do to help our patient group. Skip that bit, sorry. I always like to show pictures of the team and the workforce. I think our workforce and our people in the NHS are our key resource. No matter how many machines I have or how many bed spaces I have, without the people, we won't be able to function. We won't be able to deliver the service we do to help the community. And my favorite one is one of my nursing colleagues on the left-hand side there, who quite early on the pandemic, when the whole hospital was full of patients with COVID-19, we had nowhere to dialyze this COVID-19 patient who was desperately of need of hemodialysis. We took around one of our portable machines down to the ED department into one of the cubicles and started their treatment there. And this is not part of normal practice. I think it's the innovation and the drive of the team to provide care and keep patients safe and deliver what we can is key in first progressing and improving services. And I've got a multitude of pictures of the team working hard over the last 2-3 years, and they've always got smiles on their faces. And I'm very proud of this team that I work with. And the work we do allows us to enable our patients to reach their life goals. We work very closely with the Leicester Area Kidney Patient Association. They recognized the collaborative working that the team do and presented us this token of appreciation to the whole team. And we are immensely grateful to them for the close working relationship we have, because together we can make things better. I'm not going to talk about all the different lessons learned here. I've kind of summarized it during my talk. I hope that was informative, and thank you very much for the invitation.
Thank you very much. So we've got a couple of questions for you. The first one is, what is being done now to protect patients? As we know, there's a new wave of COVID. It's never going to go away, and people are still shielding.
So officially, I guess we all know from the government, shielding is not really there. We do know our patient group is vulnerable. Vaccination is still key. The type of vaccinations that come out are augmented to help protect our patient group. If you look now at the patients who are coming into hospital with COVID-19, actually they're not falling as sick, and there's a big stark difference compared to wave 1 and wave 2. Usually most patients are being picked up at the moment are asymptomatic or have mild symptoms, which reassures me that actually COVID-19 and the resilience of the human body and the protection we've had from vaccination is actually the key aspect we need to have. So for me, ensuring that we keep vaccination rates high is a key protective measure.
And I think you just answered the question that's just come in, really. How confident are you with the winter coming up with COVID and protection?
So I think it's not just COVID-19 that's the issue. I think it is a system with a large need of acute services and support services in the community. I think the demand is growing. I mean, I've showed you a graph right at the beginning about the growth of just renal replacement therapy. But if you look across the country and other different specialities and needs, you can see the growth is happening in all areas. And it's a basic element is resource availability to deliver that. And I don't think the resource availability is matching demand growth.
Now, last question for you. Does COVID impact kidney function?
So you'll see a variety of different things there. So COVID-19 we did see a lot of COVID-19 related acute kidney injury. COVID-19 also brought to the forefront of other conditions. So it seems to sometimes people who are more prone to immune related issues, it may precipitate that or make it more apparent. Anyone who's sick from any infection can develop a kidney injury, which then results in them having complete kidney failure or chronic kidney disease, or if they're lucky, completely resolve and be back to normal renal function. So in summary, yes.
Thank you very much for your time. So we move on to the next speakers, and the NKF is promoting home dialysis at every opportunity. And the next two ladies are very much part of our campaign. They always seem to be upbeat and supportive. It's Dinah and Patricia.
Hello, my name is Dana Holmes. I'm 47, married to Rob, and have a 19-year-old stepson called Owen and an 8-year-old black Labrador called Jasper. And I have IgA nephropathy, which I'm at end stage, stage 5, and I'm currently receiving home hemodialysis via a next stage machine, which I've named Norbit. How was I diagnosed? By pure fluke, you could say. I changed doctors in 2011 and had to have a well woman MOT, which they did the usual, asked questions, tested my water, and did blood tests. I was called later that night to say that I needed an urgent referral to a nephrologist, that I was possibly stage 1 CKD. Now, obviously, this scared me. I asked the doctor what it was and how had I got it. I had protein leakage since I had kidney stones just before my 21st birthday. And since then, the previous doctor would sort of say to me, oh, it's you with the protein leakage. My current doctor said it could be because of that, but also that I suffer with hypertension and was diagnosed with this back in 2004. I saw my nephrologist at 6-monthly intervals initially and was okay. However, this is an autoimmune disease and it attacks my kidneys. And I went quickly from stage 1 to stage 3. Holding at stage 3 till around about 2016, when I progressed to stage 4. I was feeling really fatigued, had bad cramps, restless legs, and every time I went to see my consultant, which was more regular, my kidney functions declined further. So it was now time to decide what treatment I would receive before it actually got to that stage. So time to choose which treatment. I was told all about the options of dialysis, and unfortunately, due to tissue scarring from a previous surgery in my stomach, the only option for me was hemodialysis. I was given a lot of information by the hospital, looked around the unit, and was told to go away, write a list of pros and cons, speak to my husband, and decide which dialysis would be best for me and my family. Looking around the unit, I have to say it swayed my decision towards home hemodialysis for a few reasons. So I wanted to fit dialysis around my life and not the other way around, as the disease for the previous 2 years had taken so much out of me. The second reason, I wanted to take control of my treatment, not having someone to do this for me. And the third reason, I didn't want to feel like I was ill and a kidney patient going into hospital all the time. And I totally understand that not everybody's able to do home dialysis or would want to. So getting started with in-unit HD, moved from stage 4 to 5 quite quickly, initially having my fistula operation in August 2020, which unfortunately didn't mature to the smallness of my veins. By the time I was due for dialysis, I was sleeping most of the day, some days not even getting dressed. My kidney function had declined to 8%, so it was decided I would be put on the emergency list for a neckline to be inserted, which was actually just over 2 years ago now to the date. And I started my first hemodialysis session of 2 hours. I then built up slowly during the next week or so to a total of 4 hours per session. Found dialysis very hard on my body. My blood pressure would plummet every time. My legs felt like leg weights. I had a headache throughout the session, and I really struggled to walk to the transport. I didn't feel any better. It was realised that due to only being able to have a slot 3 days per week, that a 4-hour session was too aggressive on my body. So I asked if I could start the self-care to try and take some control back, and I pursued my transplant unit to start training on the portable next stage machine, which is Norbert at the back of me. After a few emails, phone calls and stalking, I would say, on my part, they agreed to start training me up on the machine in January 2021. And as I completed self-care, I only needed to learn the machine, so I was dialysing at home within 4 weeks. So life on home dialysis, what does that look like? As we know, whether you conduct at home or in unit treatment, it doesn't come without its challenges. But both myself and my husband are fully trained on all aspects of the next stage machine, from simple alarms to emergency procedures, which we've had a few. I changed the way I dialysed to 4 times per week at 3-hour sessions, and this seemed to work well and wasn't that aggressive on my body. However, after only 4 months, my neckline started to alarm each time, and I wasn't getting a good dialysis as I should have been. I ended up in hospital with it being flushed and then an infection, so pumped full of antibiotics. My surgeon decided it was time to revisit my original fistula and look at inserting a graft, which is a tube in my forearm, to open up the veins and connect my vein to my artery. So I had this done in May 2021. This was a success. And apart from 2 weeks of needling training, which I went back into the unit, I was back home again. I still had a few issues along the way. For example, only a couple of weeks ago, I was in hospital due to my veins narrowing. So I had to have a procedure called angioplasty, which was to balloon the parts of my veins that had narrowed at the top and bottom of my graft. However, I am back to my routine home dialysis, and everything, touch wood, seems to be going fine. So what does the future hold? Although I am a peer supporter for the National Kidney Federation and very much an advocate for home dialysis, which I will shout about to anyone that listens, I'm on the transplant list and I've been since March 2020. But as we know, COVID had a big part to play in the delay of transplants. I remain as positive as I can, the hope that one day I will get that call and the transplant will go ahead. But during lockdown, I created a company called Quick Designs Limited, which provides clothing for dialysis and other IV treatments, which gives you quick and easy access as well as keeping you warm. And that was one of my main focuses, keeping you warm, as I was always cold on dialysis. I am very hopeful that this takes off, and with each sale, you can have the comfort in knowing that a donation is given to my local KPA of Saka. So now I would like to hand over to one of my colleagues called Patricia Gooden, who is also on home dialysis.
Good afternoon, everyone, and thanks to the NKF for inviting me to speak today. Yes, I'm going to be talking to you about PD dialysis today. First of all, I want to talk to you about where everything began. I was actually born in the UK. My mother died when I was 2 years old. And when my dad remarried, he decided to take us to live in the Caribbean, Jamaica to be exact. and I grew up there as a child. Now, during my childhood, I always felt a bit ill, but couldn't really determine what was causing it. And as a child as well, I wasn't sure if it was in my head or if it really was happening. Anyway, I will expand a little bit more. I came back to the UK in the late 80s. I should say I had my first child in Jamaica. And when I brought him to this country, he was 9 months old. And the end of this year, he'll be 40 years old. So I've been here quite some time. Now the diagnosis. I became pregnant in 1993 with my second child. And I started to feel really ill. So I went to my doctor and I said, "Doctor, I think I'm pregnant, but I also think I'm diabetic." The GP made an appointment for me to actually go to the hospital to get tested. I was tested the following day, and yes, I was pregnant, and yes, I was also diabetic, and I had to go on insulin that very, very day. And during my 9 months of pregnancy, I had to undergo intense monitoring so that the baby would be born with the right weight and not actually develop diabetes as well. Now I've called this one education. During my illness, or late, by the time my daughter was about 10 or whatever, I started to be constantly sick, always vomiting. And the doctor sent me for a scan. Whilst doing the scan, the technician turned to me and said, "How do you feel knowing that you have kidney failure?" I had no idea that I had kidney failure. I don't know how I got home. I know I drove home, but I can't remember the journey. I was then put in low clearance. And in low clearance, I remember being put in front of a television with videos showing me what dialysis is all about. I had absolutely no idea what I was looking at. And I was in a daze, to be honest. And I made a vow that day that when I know more about dialysis, that I will never allow any patient that I know to go through what I went through. Absolutely no education at all. I was told that when my appetite drops, then it means that my kidney failure would have probably gone to a really bad stage. So I had a catheter fitted roughly a year and a half in advance. That Christmas 2012, I think it was, no one realized that I wasn't eating. I did all the cooking and everything and was running around everyone, but no one noticed that I was just picking at my food. And a couple of days after Christmas, I actually fainted in the house and broke my ankle. I was rushed to Princess Alexandra Hospital and then sent to the Royal Free, and that's where my PD dialysis started. Now, once on PD, well, before I started PD, to be honest, officially, someone came to the house and did it for me. Then I was given the training. I was sent to Kew, where Baxter's did a fantastic job of showing me how to use my machine, telling me everything I needed to know. And I can't thank them enough for what they did for me in those days. I became familiar with it. I knew how to set the machine. I knew how to order my stock, etc. By then, my children had left home and I was alone at night in a big house by myself in Epping. And I became really, really isolated. Thankfully, Baxter's, the nurses provided a lot of support, but I also wanted to meet other people. I went to my GP and I asked if she could introduce me to anyone else who's doing this type of dialysis. But unfortunately, I was the only one in the area doing dialysis. The thing about PD is that I was able to do this at home by myself in my own time, and that's why I chose PD, because I was still working and I needed that flexibility. If I had a problem, there's a number that I can ring and it's answered in America, and you can ring that number 24 hours a day, whatever you want to, 24/7. I was supported by the PD nurses. And believe it or not, I was able to go on a Mediterranean cruise with my daughter. And that was one of the happiest things about PD. Everything was shipped out there for me. The staff, and to be honest, they upgraded me and I became a VIP patient. And I'm grateful for that. Sorry, my slide, right. Anyway, I was on dialysis, then I had a transplant. And my transplant happened in 2014. Unfortunately, I then had to go back on PD because my kidney rejected, and I started PD again in 2021. And you can see a photo of the PD machine. Of course, there were tears. I was really, really devastated. I just couldn't see the future at that time. However, now I'm back on PD. I decided to stay with PD again because of the flexibility, and I'm used to it. I now there's a company called Bionicle, and this is better for me than before. Now that my mobility is not as great as it used to be, I have a technician who comes in every day who will set up my machine for me, and all I do is connect and disconnect myself. And this is really helping me to enjoy this second stage of PD even more than PD, even more than I did the last time. Next slide, please. Don't know what happened. Now, how do I feel today? At 8:45 every evening, I prepare myself to go on my machine. It doesn't have to be 8:45, but that's the time that I've set for myself. So that I'm usually on the machine before 9 o'clock. I work out the calculations. It's automatic now. If I'm on at 9, I come off at 6. If I'm off at 10, and at 10, I come off at 7. I feel educated now. I understand it more than I did before. I can talk to my fellow kidney patients. And as said earlier, I'm actually a peer supporter, and I support other kidney patients who want to be on PD. I'm engaged in charity work, and I'm engaged with my local KPA at the Royal Free Hospital in London. Next slide. What next, you want to ask me? Well, I am waiting for a new kidney. As I said earlier, I'm an NKF peer supporter. I work with Kidney Research UK. I'm a trustee for Kidney Care UK, and I'm a committee member at the Royal Free Hospital KPA. I keep myself busy. I tell my family I'm all things kidney. Next slide, please. Conclusion, I just want to say thanks to the NKF, to Kidney Care UK, to Kidney Research UK, to my local KPA and to the president of my local KPA, David Myers, who helped me with the photos you see today on my slide, and to Pete. Thank you all for listening. Hope you've learned something from me. Any questions? Thank you.
Well, thank you very much, ladies. No questions at all for you two. So you've obviously covered everything perfectly. So as we come to the end of this virtual event, I'm going to hand you over to Jim, the NKF chairman, for his final remarks.
Well, hi there. Wasn't that a really, really good conference? And I'd like to thank every speaker that's attended today and every delegate that's managed to log into us. As you know, the council meeting will take place at 2 p.m. and the Zoom link for that meeting has been sent to everyone who have registered to attend it. And as this is my last year as chairman, I would like to thank everybody in the team at the NKF and all the KPAs that I've met in the past, and hope to see most of you at the KPA Day next April, ready for the AGM when we will have found a new chairman. So no more from me, just thank you very, very much for all patients and speakers for today's event. Thank you.